Thank you. Morning. All right, let's go ahead and settle down and get started. And then as more people show up, I've had a few emails and texts saying people are still on their way. Apparently, there's a lot of traffic along the way. It took me over an hour to get here from Windsor, so it's been a wild week or so. Thanks everybody for your patience the past week or so. I was out of my house for about a week due to the fires, and so I'm sorry for not being as responsive as usual with the emails and things, but I'm getting caught up now, and so everything should be back to normal by the end of this week. So for the people who turned in their website assignments already, that's my last thing on the list to grade this week. So I'll get that out by the end of the week, and we should all be caught up at that point. This week we did the National Certification Prep exam instead. A lot of people have been emailing me saying, like, I bombed, this is the worst thing ever. Please don't be discouraged. One, we're only a little over halfway through the program, so you're not expected to know everything at this point. Two, this was purely for the experience of taking these types of exams and getting used to the style of the questions and things like that. It's really more for the experience. I think in years past, the average was only like 50 to 60% anyhow. So don't be mad if you got 50 or 60%. That's normal. It's really just so that you could have the experience and know kind of ballpark what to expect when you do take the exam. Plus, it helps to guide you a little bit in terms of areas where you might want to practice a little bit more. So really, was that? All of it? Well, yeah, if that's the case, then practice on it.
On that test, you can like subject,
yes,
to see where that was really helpful.
Good.
That was very helpful.
So that was the point of the exam. It really was just for the experience. Don't be discouraged. If you did that exam, I'm going to get a report in another day. I'll probably receive the report. Oh, they might have sent it today now that it's Tuesday. But they're going to send me a report showing who actually participated. Whoever participated automatically gets full points for the quiz this week, regardless of whether or not you even attempted the quiz this week. Okay? If you did,
We get extra credit. We did the quiz too.
not extra credit, but you get full points automatically. So I'll have to go in and manually change the grades for everyone's quiz. So you might notice that you got the quiz says you failed, but then when you look at the actual quiz results, you'll have 10 out of 10 points. So don't worry, you're going to get full points if you did the practice exam.
Will you still show the answers for the quiz?
Yeah. I'll kind of post a little bit about reasonings for some of the questions, and just like usual. And then I'll also just kind of reiterate what I just talked about with the national prep exam, because I think some people are a little nervous about how it went. So don't worry, it was just for the experience. So I would like to introduce Dr. Athale. He's going to be doing our lecture today and has been here in the past as well to help us out, and we really appreciate him coming back. He's done a wonderful job in the past. So everyone, if you could please welcome Dr. Athale.
Thank you, guys. Do you need to do any testing with the sound, or we're good? Okay.
We hear you pretty.
Okay, perfect. So I'm Ninade Athale. I'm a family practice physician. I practice out in Napa. I hope all of you guys have been safe over the last couple of weeks from the fires and everything that's been certainly disruptive in Napa as well. I will be talking today on endocrinology, specifically thyroid hormone dysfunction and diabetes. The majority I'm going to try and take up with diabetes, obviously, because that is probably one of the most important things that you guys can learn about. I'll be lecturing later on in December on substance use disorders and mental health disorders. So between diabetes, mental health, and substance use, it's a lot of pressure to cover everything, 90% of what you're going to see in primary care in just 5 hours. So we'll do what we can. But we'll start with thyroid function first. If there's any questions, please just raise your hand. I don't mind being interrupted during the presentation. We can also wait till the end. I'm going to try and get through the thyroid slides pretty quickly so that we can move on to diabetes. So we'll start with a basic introduction, physiology of thyroid hormone, talk about hypothyroidism and hyperthyroidism, which is really essentially what you need to know for this lecture, and then a few special cases. So these slides, I believe you're going to get a copy of them. And what I tried to do this year, I did this lecture 2 years ago. And so I put a little lightning bolt, because that was the easiest graphic that I could find that symbolized importance, to indicate a slide that's particularly high value in terms of primary care in terms of testing, stuff like that. So when you go back to the slides, you can see which are the slides to really focus on. And I did this for the diabetes lecture as well. So, thyroid hormone is a very important hormone. It has far-reaching effects in the human body. Nearly every organ system is affected by thyroid hormone. The primary functions of thyroid hormone are the regulation of metabolism and what's called the basic or basal metabolic rate, growth and development, particularly in the developing fetus and in neonatal brain development. And then thyroid hormone affects the regulation of many other organ systems, cardiac, gastrointestinal in terms of GI motility, reproductive system, brain function, and water clearance or water regulation in the body. So as you all know, or some of you may know, thyroid hormone is extremely important and is a common thing that thyroid dysfunction is a commonly seen problem in primary care. So, the hypothalamic pituitary axis. We're not covering other endocrine disorders today, in terms of reproductive systems, etc. But the hypothalamic pituitary axis is a very important endocrinological system. The hypothalamus is located in the brain and is a primary central regulator of the endocrine system. The pituitary gland sits just below the brain in what's called the sella turcica, which is in the skull, and secretes multiple hormones. I'm not sure if you get other endocrine lectures on anterior pituitary hormones, but the flat peg mnemonic is very important to remember. FSH, LH, ACTH, TSH, which we're going to talk about today, and then prolactin and growth hormone. Those are the 6 anterior pituitary hormones. I just mentioned those because in the future, hopefully you'll get some lectures on those, but we're going to talk specifically about thyroid stimulating hormone. So signals from the hypothalamus stimulate the anterior pituitary to secrete thyroid stimulating hormone. As its name implies, the thyroid stimulating hormone stimulates the thyroid gland, which sits in the central part of your neck just below your vocal cords on either side of the cricoid process area. And the thyroid gland is responsible for secreting thyroid hormone, or T4 as it's called, or thyroxine. T4, the 4 refers to the number of iodine molecules that are attached to this thyroid molecule. And T4 is actually an inactive hormone as it's secreted from the thyroid gland. It's basically circulating through the bloodstream. The majority of it is bound to thyroxine binding globulin protein. And when it gets to the sites of action, it is converted into primarily T3, which is the active version of thyroid hormone. And T3 acts within the cells. This negative feedback loop is very important. T4 and T3 negatively feedback on the pituitary gland to decrease production of TSH. So the idea of negative feedback loops is very important in endocrinology. When you have high levels of TSH indicating that the body is trying to make more thyroid hormone, eventually once the thyroid hormone is produced, it sends a signal back saying, okay, we've had enough, we're good, and we'll shut it down. That's why this will be apparent later, why it's very important to understand the workings of TSH. Again, the thyroid gland produces T4 and T3 in some small amounts, but the majority circulates in the blood as T4 bound to a protein, and then it's converted to the tissues to T3, which is the active form. And T3 exerts its main effect on gene expression within the cells of various organ systems. This is what the thyroid molecule looks like, the thyroid hormone molecule. This is T4, 1, 2, 3, 4, and T3 would be without this iodine. So let's talk a minute about iodine, because iodine is the most important element for the production of thyroid hormones. And it's important to know worldwide, for any of you that will be doing rotations abroad, it's not as big of an issue in the United States, but iodine deficiency is the leading cause of hypothyroidism and preventable developmental and intellectual delay. parts of the country, or in other parts of the world. We're going to skip this for right now about concepts about how iodine actually regulates the production of thyroid hormone. We can come back to that later if anyone has questions. So, the regulation of thyroid hormone is extremely complicated, extremely complex. Why is it so complex? Well, regulation occurs via signaling from the anterior pituitary using TSH, synthesis in the thyroid gland, so various regulating mechanisms can act on these various sites. Transport proteins, depending on the level of transport proteins in the blood, you'll have more or less available thyroid hormone. Conversion of T4 to T3, which is the active form of thyroid hormone. And then the receptors themselves within the cells are regulated. The reason for this complexity, the reason why this is so confusing, is that in order for thyroid hormone to be able to act so differently on various hormone systems, there has to be a high degree of complexity in the regulation, right? If you have a system that's regulating GI effects, that's regulating cardiac effects, that's regulating your basal metabolic rate, you have to be able to fine-tune that system for the various organ systems. So that's why you have this complexity. It allows for the ability of a single hormone to act differently and with different intensity on different organ systems and under different conditions. How did this come about? This is probably evolutionary adaptation that allowed us to develop this complicated system. Any questions on the physiology up until this point? We'll get into now the more clinical aspect. So, hypothyroidism and hyperthyroidism. Anybody know who these two people are?
Yes, this is one.
Siskel and Ebert, right? So, they're caricatures of what you might think of as hypothyroidism and hyperthyroidism. Neither of these people had thyroid endocrine dysfunction, although, does anyone know how Roger Ebert died? He actually had thyroid cancer, so it's sort of appropriate. But and Gene Siskel died, I think, of another type of cancer complication related to surgery. But so you can think of the effects of thyroidism, hypo and hyperthyroidism, as a spectrum, right? On the top level here, when you have an absolute deficiency of thyroid hormone, these are the kind of illnesses you see, from myxedema coma, which we'll talk about later, which is the absolute deficiency of thyroid hormone. Then hypothyroidism, subclinical hypothyroidism, which is to say that you have a low amount of thyroid hormone. You're not necessarily exhibiting the clinical symptoms of it, but when you measure it, your thyroid hormone is low. This is important to understand as well. Euthyroid is just the name for what we call a normal thyroid state. Being the Greek prefix for good or normal. So when you hear people talk about euthyroid, just know that we're talking about a normal functioning thyroid state. Then on the other end, you've got subclinical hyperthyroidism, overt hyperthyroidism, and this syndrome called thyrotoxicosis or thyroid storm, which is the opposite of an absolute deficiency, which is way too much thyroid hormone, and the end results of that. So even though you can kind of think of this spectrum with hypothyroidism being the opposite of hyperthyroidism in terms of symptoms, which we'll see in a bit, the reasons for the pathophysiological reasons for these different states are very different. So it's important not to just say, oh, all hyperthyroidism is basically, too much thyroid, and hypothyroidism is not enough thyroid. The physiological reasons are actually very different. So what do you really need to know as a primary care provider? That's what I'm really gearing this lecture towards, is the understanding of what you do when you see thyroid dysfunction states in the primary care clinic. So it's absolutely important to know the evaluation and management of hypothyroidism. This is something that primary care providers do all day long. In terms of hyperthyroidism, it's important to recognize those syndromes and the initial treatment and evaluation of those. It's important to know about other treatment options, but generally speaking, if you have access to an endocrinologist in your community, most of hyperthyroidism should be treated by an endocrinologist, at least evaluated by an endocrinologist. It's also important to recognize these extreme cases of mixed edema coma and thyrotoxicosis, which are going to be treated in the inpatient setting or in a hospital. But it's important to know what they look like and when to send people to the emergency room. So again, this is a lightning bolt slide. The list of symptoms for hyperthyroidism versus hypothyroidism are here, and I'm not going to read through all of them specifically, but just know that there's a dichotomous relationship between these symptoms, right? For hyperthyroid states, you tend to be irritable, you tend to be anxious. Hypothyroid states tend to be ones in which you experience fatigue, depression. You know, in terms of GI symptoms, hyperdefecation versus constipation. In terms of cardiac tachycardia versus bradycardia on this side. And some of these other symptoms that are specific to one of these states. Exophthalmos is specific to Graves' disease, which we'll talk about later. Goiter can actually be common to both hyper and hypothyroidism. We'll talk about what a goiter is later. Let's see if I have edema, mixed edema, which is a very specific type of edema, which we'll talk about later. So this slide is one of those slides that you're going to want to look at and sort of commit to memory later. And also know that any one of these symptoms by themselves is not going to point you to thyroid dysfunction, right? These are all very generic, very general symptoms. If someone comes to you just complaining of a tremor or irritability or anxiety, you know, that could be a whole range of different illnesses. So let's talk about a brief case study. I'm including some of these case studies just to make it more interactive here. So you're called, let's say you're working in an urgent care rather than, you know, you're called in to evaluate a woman for fatigue and anemia. So there's a 57-year-old female. She appears older than 57, and she's complaining of severe fatigue, right? At first glance, a very general symptom. On exam, she's somewhat tachycardic, actually, but you notice significant hair loss, swelling of face and the extremities, and what you particularly notice is that the swelling on her lower extremities has this doughy characteristic. It's very, has anyone seen mixed edema or seen this kind of swelling in patients? So there's no other way to characterize it besides saying doughy. You know, it's like a very squishy, a very dry skin kind of appearance. And so that's something to, if anyone has not seen that before, it would be useful to try and find these patients, these severely hypothyroidism patients in your clinic, so you can see what this looks like. On exam, she appears just generally sluggish. She has poor reflexes. And you order some basic labs in the urgent care clinic, and hemoglobin comes back at 7.2. So she's clearly anemic, right? She's tired. Done, right? Diagnosis solved. Are we done here exactly?
No.
So let's talk a little bit about hypothyroidism first. The epidemiology, the common causes, and diagnosis and treatment. This is what that lady looked like. This was a stock photo, so I tried to match them up as well as I could, but this is actually a real patient that I remember from residency, and this is actually what she looked like somewhat. So again, the common symptoms of hypothyroidism, I'm just repeating them here. Interestingly, she did have tachycardia, right, instead of bradycardia. Why do you presume that is? She was anemic, right? So there can be competing mechanisms. So it's not like when you see a hypothyroid patient, you're going to just go off this list and check everything off. Be like, yep, they've got all of these. It's case solved, you know. The epidemiology of hypothyroidism. This is a survey. This is about 15 years old or so, but around 3.7% of the population. Definitely more common in women. I've heard studies say about 5% of the population, which is to say that any disease in 5% of the population, you're absolutely going to encounter this in your clinic at some point. And I'm sure all of you that have done clinical rotations have encountered patients that are hypothyroid or at least on thyroid replacement, right? So what are the causes of hypothyroidism? Sometimes it's hard to know, right? Like someone comes in, that lady came in and her thyroid hormone levels were extremely low. At that point, it doesn't really matter what caused, it does matter, but you're already seeing the end result of it. But it's important to know because most cases, and I want to say this is around 80% or so of cases of hypothyroidism are from what we call Hashimoto's disease or Hashimoto's thyroiditis, which is an autoimmune condition. So your body, just like other autoimmune conditions, you produce an autoantibody that attacks thyroid peroxidase, which is an enzyme in the thyroid gland. So basically you're attacking the thyroid gland and you're destroying the ability of your body to produce thyroid hormone. So eventually you're going to be left with a deficiency of thyroid hormone. Some of these other cases here, we'll be touching on these a little bit later. Postpartum thyroiditis, I'll talk about at the end as a special case. Drug-induced, very important to know, I'll talk about this at the end too, about the drugs that interfere with thyroid metabolism and regulation. Iatrogenic, we'll talk about this later. Subacute granulomatous thyroiditis. Thyroiditis is inflammation of the thyroid gland, which can lead to a low thyroid state or hypothyroidism in transient way. I'll talk about this later. And we talked a little bit about iodine deficiency. This is something that you're not likely to see in the US as much, but in other countries. So, how do you diagnose thyroid disease? The TSH is a most sensitive marker for thyroid disease. I'm going to see if I can do this real quick, going back to the regulation slide. So the TSH is produced in the anterior pituitary, right? You would think, okay, if I want to measure if someone is deficient in thyroid hormone, why don't I just measure thyroid hormone, right? That seems to make the most sense. Thyroid hormone in the body is not easily measurable, right? T4, free T4 is a small percentage of the total amount of thyroid hormone, or thyroxine, in the system, which is normally bound to protein. You can measure T3, you can measure reverse T3, but because of this feedback mechanism, the TSH is actually the best thermostat, or the best regulating marker for what your thyroid state is. But what's important to know is that if your thyroid levels are really low, and you have a low amount of thyroid being produced, you're not getting this negative feedback, so your TSH levels are going to be very high. Your TSH levels are trying to tell your thyroid hormone, hey, I'm not seeing a lot of thyroid hormone, let's step it up, let's make more. In the case of Hashimoto's or other hypothyroid states, your thyroid hormone is just not able to make the hormone. So your TSH is kind of still saying, hey, what's going on? Let's ramp this up. So your levels of TSH are going to elevate significantly, but what you're actually seeing is a hypothyroid state. Does that make sense to everyone?
Yeah.
Because this is a very important concept that when you're dealing with thyroid disorders, you're going to deal with this every day. You're going to see TSH levels, and you're going to have to understand what that means. So, a normal TSH is roughly between 0.4 and 4, and usually that means normal thyroid function. Any reference lab will give you the ranges of what your TSH levels are. Remember, if TSH is up, then usually thyroid hormone is down because of the negative feedback loop. I'm going to go briefly aside for a second, sideways, and talk about screening for thyroid disease in asymptomatic adults, right? Because you've got a very good test. TSH is a very reliable test. So what is the recommendation on screening? Remember, a screening test is what you'd administer to the general population, right? So if we just want to find out if anybody in this room has thyroid disease, we would just administer a TSH to everyone, regardless of whether or not you have symptoms or not. And as you go through your rotations, you might have various preceptors say various things about whether or not people should be screened. That's to say that everyone that walks in the door, just like you want to screen them for diabetes, or you might want to screen them using questionnaires for alcohol or substance use, just like that, you just screen them for thyroid disease. Some people say you should. The American Thyroid Association says that women and men over 35 years of age should be screened every 5 years. Generally speaking, the association for a particular illness is going to want to screen that illness in a higher frequency. It's a strange thing how that works. Thyroid doctors want to find a lot of thyroid disease. this is true of the PSA, right? This is much more aside than I meant to go, but if you ask urologists about using PSA for screening, absolutely every one of them is going to say yes, PSA should be used for screening, right? Family practice and in general, we avoid using the PSA. But so it's important to know that when you see these recommendations from various sources, you know who's giving the recommendation. This is not to malign endocrinologists or thyroid doctors, but this is just to say that it's important to recognize where these are coming from. The American Academy of Family Physicians says patients greater than 60 years of age should be screened. I'm not really sure what the evidence for that is. The U.S. Preventive Services Task Force, which is really the accumulation of the best evidence, really, and recommendations. It's not necessarily evidence, but it's general recommendations, says there's insufficient evidence for or against screening. And the Royal College of Physicians in London, if you really want to see what the most economical suggestions are, then if you go to the UK, because of their national health system, you know, they're definitely going to be the most conservative. And they say screening of the healthy adult population is unjustified. So, again, though, screening is not the same as testing for a diagnosis in patient with symptoms, right? The symptoms of hypothyroidism are very nonspecific. So even if you were to say anyone that comes in with depression and obesity, which, you know, that's going to be some percentage of your population, maybe 80% of your population, even if someone comes in with mild degree of mood symptoms, are you going to order a TSH to screen for that or to diagnose that? It's a difficult question to answer. Any questions on that little aside real quick? This is an area of clinical discretion, I would say. Okay, so let's jump back to hypothyroidism for a second. So remember, if the TSH is high, you would suspect hypothyroidism. Your next step would be to screen following up with the free T4 and T3 labs. These labs can be ordered. Usually they're part of a reflex, which means that anytime a TSH comes back abnormal, usually the lab will, depending on whether you order it, will say, okay, something's not right, let's just follow up with the thyroid hormone levels. If free T4, T3 is low, then essentially you have your diagnosis. If free T4 and T3 is normal, then you're sort of left in this gray area. Is this subclinical hypothyroidism? Is this the beginning, potentially, of a Hashimoto's thyroiditis, where you're just catching an early phase of the autoimmune disease where you're starting to trend it down? Absolutely, it's a good idea to follow up a TSH level in a few months. And then you could consider ordering the anti-thyroid peroxidase antibody to see if, in fact, this is autoimmune or Hashimoto's thyroiditis. So, you know, we gave you the range of TSH between 0.4 and 4, let's say roughly. It's not uncommon to get a TSH back of 7 or 9 or 10. And a patient is saying, when you ask them, they say, okay, yeah, I'm a little bit tired, you know, yeah, I'm a little bit sluggish. Do you have constipation? Oh yeah, I have constipation all the time. Not to mention that they're on hundreds of milligrams of morphine, right? Patients with true hypothyroidism, like the picture of the lady you saw, the picture of the case presentation we saw, those people will have a TSH in the 50 to 100 range. That's when you really see, when the TSH is saying, hey, what's going on here? I'm not seeing any thyroid hormone, and your anterior pituitary is really trying to jack up the level of TSH. So if you see mild elevations of TSH, it's sort of also a judgment call as to whether you treat that as subclinical versus clinical that you'd want to treat. Make sense so far?
So you treat based on the presentation?
You would treat based on clinical symptoms, correct. You treat based on presentation. And so in my practice, I deal primarily with the mental health population and substance use population. So patients that are being treated in a psychiatric clinic for depression, let's say, will come back and say, their psychiatrist will send me a note saying, TSH is 7, please see your doctor. And I'll have a discussion with the patient. It's like, okay, you know, it's reasonable to try a low dose of thyroid hormone to see if your depression symptoms improve, and try and normalize that TSH. That's absolutely a reasonable thing to do. It's also reasonable, I think, to kind of wait and see and trend that TSH, you know, regularly to see if we see any changes. Because like I mentioned before, there's other drugs that can affect thyroid hormone levels, and so you want to take that full picture into account. But if you see a TSH that's significantly elevated, you know, I'm saying like over 10 really is my cutoff in my mind where I'm thinking, okay, like I do want to treat. Does that make sense?
Is
Yes.
there anything other than medications that can temporarily raise the TSH? I mean, you know, so they come in with a 7 one time and then they come in with a, 3.
So like are there things that can interact with the lab test or that can falsely maybe elevate a
Right,
TSH?
either physiologically or
Yeah.
laboratory.
That's a good question. There are a lot of things that can affect the levels of T4 and T3 and thyroid hormone. The reason that we use TSH is because it's produced in the anterior pituitary. I'm going to have a lot of trouble saying that repeatedly. And it is a very reliable test. So, you know, I don't know of a lot. I can look that up. I can make a note of that. I don't know a lot of things that falsely change your TSH level, besides dysfunctions in the pituitary or in the hypothalamus or something like that. So if you see an abnormal TSH, there is something going on. But you know, you're not really clear whether this is a subclinical disease that needs to be treated or it's a progression of something, or you know, if there's something that's interfering with thyroid hormone, absolutely. Like if you're on lithium or amiodarone and your thyroid hormone levels are abnormal, that will affect your TSH. But that's not to say that your thyroid levels won't normalize later, and therefore your TSH level will normalize. Does that make sense? Does that answer your question?
Yes, thank you.
So, treatment of hypothyroidism, very straightforward. You initiate treatment with thyroid hormone replacement. Levothyroxine or Synthroid is synthetic T4. It's the standard treatment in primary care settings. Very reliable dosing. You want to remember this. You want to start at generally a full treatment dose is 50 to 100 micrograms. Remember, this is micrograms, not milligrams. The dose is very small of thyroid hormone. The average treatment dose for a healthy person is around 125 micrograms. Some people need more, some people need less. In patients with cardiac disease, this is the one caveat, is that older patients or patients with cardiac disease, any kind of cardiac disease, arrhythmias, coronary disease, want to be a little bit more careful. Unless they're profoundly hypothyroid, if they're sort of a little bit off, it's reasonable to start at a lower dose, make sure they tolerate it, and realistically the TSH compensates or equilibrates every 4 to 6 weeks. So it's one of the annoying things about thyroid management is that you got to get these people back in regularly, every 4 to 6 weeks. Make sure they repeat their TSH. Make sure you've got the right dose. You know, these are not patients that necessarily are high maintenance that need to be seen in the clinic all that often, but you know, getting labs back, you know, someone goes, you say, okay, go get your labs in a month. You know, it's 2 or 3 months later, and you're still giving them a thyroid hormone dose that's too low or too high. These patients do need to be monitored and followed up with. You can titrate up faster every 2 to 4 weeks if they're symptomatic and they're relatively healthy. And generally speaking, if you have a patient with hypothyroidism and nothing else, once they're stable on a dose, they need to be followed up yearly with a TSH to make sure their dose is fine, that they haven't, you know, gained a lot of weight or lost a lot of weight, or you know, on new medications that might interfere. But once a year is reasonable. So these patients are very readily treated in a primary care setting and don't necessarily need to be referred to an endocrinologist. Questions about treatment?
I do.
Yes.
So, what's the reason for cardiac disease? Is it like arrhythmias that you're monitoring for?
Yeah, so if you overshoot the mark, if you give someone a dose of thyroid hormone and it's too high, then they can start developing tachycardias and arrhythmias because of the effects of thyroid hormone on the cardiac system.
Got it. Okay.
I'm going to mention here 2 other forms of thyroid hormone that you may see people on. Armour thyroid is desiccated bovine thyroid hormone. This was what was used prior to the development of synthetic T4. It's not good because it contains a mixture of T4, T3. It's sort of, you know, just an older treatment form. Some patients, you may still see some old school patients that are on this and, you know, are adamant that this is what they want to be on. You know, I would say they probably deserve a little bit closer monitoring in terms of their thyroid function. Sometimes people will use Cytomel or T3, which is more rapid acting. There's better GI absorption in cases where you really need to increase someone's thyroid hormone a little bit more rapidly. Some people are on a combination of T4 and T3. To be honest, the majority of hypothyroidism patients can be managed by T4 or Synthroid or levothyroxine. So this is not something that I've ever started. If someone's on it, then I may continue it or may refer them to an endocrinologist for management. So we're going to move on. Any questions on hypothyroidism before
What
we
would you prefer? I mean, you're giving the patient, you know, you're monitoring them, the TSH, you're giving them, you're titrating them, right? You're trying to find that balance. When do you refer in that case?
So if you're having a really hard time trying to find that TSH range, right? Let's say you're giving, you know, there's a couple of scenarios, right? Are you giving them a lot of thyroid hormone and you're not bringing their TSH down? They continue to be hypothyroided, or is the TSH continues to be super elevated, or something clinically is not making sense? Then you would refer. I mean, usually it's worth a couple months of trying to, you know, adjust a dose, trying to measure the TSH, especially for a patient with hypothyroidism who's not overtly clinically failing, I guess I should say. There are certain cases where you could be fooled by some of these disease states. So, you know, I guess an adequate rule of thumb is that as opposed to hyperthyroidism, hypothyroidism, I think it's worthwhile trying to manage someone for at least 3 to 6 months, unless, you know, there's a red flag going off and then you try and refer them to an endocrinologist. It's different, you know, I don't know what the different communities, and depending on where you practice, if you practice in a underserved low-income setting like I do, and in our community in Napa, there's just an incredible shortage of endocrinology consultations. So, you know, we end up doing a lot of this stuff on our own. Some of it is just guided by whether you have an endocrinologist that you can easily consult, that's taking patients, that you can call up on the phone, or, you know, how difficult that is. But, you know, you can always err on the side of referring if you feel that there's something that's making you uncomfortable. Does that make sense?
Yeah, no.
Sure.
I had a patient yesterday who was on levothyroxine, and we had overshot it a little bit. Her TSH was 0.29, but she felt great, and she did not want us to adjust her
Yeah.
thyroid medication.
Yeah.
So is there a safety window where you really need to be within a therapeutic range?
Yeah, very good question. We'll talk about that when we talk about hyperthyroidism too, because when you see true hyperthyroidism, you'll see the TSH also driven down to almost undetectable levels. So if you have a TSH of 0.2, 0.1, you know, depending on who you talk to, there is a case to be made to maintain someone at that, you know, slightly hyperthyroid range. Some psychiatrists I've seen will do that. Some psychiatrists will treat people with thyroid hormone for depression without a clear indication of hypothyroidism. So I wouldn't say that's a standard of care. I would say that the standard is probably to try and, you know, adjust them accordingly. But, you know, patients are people, and I'll talk about this when we talk about diabetes. That I can give you all the data and all the guidelines and the statistical evidence, but when it comes down to actually negotiating with a patient, you know, things are going to be a little bit different. So, you know, for that patient, I would say that's reasonable. Let's check your TSH, you know, every 2 months or so, and like make sure you're not doing poorly, and you know, just kind of go from there. If there was an endocrinologist standing up here, there might be a different answer. So I just put that caveat in there for you and for the camera. Okay, any other questions? So let's talk about hyperthyroidism. This is another case that I've seen. 24-year-old Latino male comes to the clinic. He's brought in by his mother, complaining the patient is acting out and acting bizarrely. He himself is not very communicative. He kind of comes in as just kind of staring ahead blankly. The mother tells me that he's frequently found talking to himself, that he's hearing voices. On exam, he's tachycardic, He has a mild tremor. He appears to have bulging eyes when you look at him, like something is just not quite right with his eyes. There's a questionable fullness in his neck when you examine, although you could be psyching yourself out about this exam. So the diagnosis, because I see primarily mental health patients and they're coming in with these mental health symptoms, is this psychotic disorder? Is this a new onset schizophrenia? I mean, he's a 24-year-old male. I mean, this is a typical age for a potential psychotic break. Again, are we done? Well, obviously not. This is not the patient. This is another stock photo. But, the striking finding is the exophthalmos, which you see in Graves' disease. So let's talk about hyperthyroidism, right? Epidemiology, causes, diagnosis, and treatment. The incidence of hyperthyroidism, of true hyperthyroidism, is much lower than hypothyroidism. You're going to see this in the course of years, but this is not like a bread and butter primary care kind of disorder. You can see the incidence between 0.05% and 1.3%. The majority of this is actually subclinical disease, where you see elevated levels of thyroid hormone, maybe in the setting of a thyroiditis or something else, which we'll go into. But of those with hyperthyroidism, the incidence of thyroid storm is 1% to 2%. So that's not a huge percentage, but thyroid storm or thyrotoxicosis is a potentially fatal disease, and it does need to be caught, right? So again, these are the symptoms. Talk about exophthalmos in a second. I forgot to mention, intolerance to heat and cold is one of those questions that's on your endocrinological review of systems, right? And that's a sort of a good, it's also nonspecific. Like you ask anyone, do you tend to feel really cold? And they're like, oh yeah, I really get cold all the time, and that could just be how a person normally is, or the basic metabolic rate. But intolerance to heat and cold are those two questions that kind of make you think about thyroid disorders as well. So the causes of hyperthyroidism are a lot different than the causes of hypothyroidism, obviously. And there's several different types of diseases. Graves' disease is probably the most common and the most serious one that you need to be aware of. Graves' disease is, again, an autoimmune disease in which anti-TSH receptor antibodies are produced. So basically, these antibodies are mimicking TSH and stimulating the thyroid hormone to produce thyroid, or stimulating the thyroid gland to produce thyroid hormone. These other entities, toxic multinodular goiter, are where there's multiple nodules in the thyroid gland that are all producing thyroid hormone. And usually that happens because of some iatrogenic event or something that set that off. Whereas a toxic adenoma is basically a single nodule or single focus of increased thyroid production in the thyroid gland. And these are basically, they're not cancer, but they're autonomous nodules that have escaped regulation, and they're just saying, kind of going off on their own. There's like a little pocket that's saying, hey, we're going to make thyroid hormone. We don't care about what anyone else is telling us. These are a result of genetic mutations. And then subacute thyroiditis is inflammation of the thyroid gland in the setting of a virus, which may lead to a release of thyroid hormone. We didn't talk about thyroiditis. We'll talk about that towards the end of the lecture. I'll go through these in a second. So again, the opposite of hypothyroidism, you're going to use your TSH as your diagnostic tool. If your TSH is low, you're going to suspect hyperthyroidism. Follow up with a free T4 and T3. If those are high, then you've got your diagnosis of hyperthyroidism. If they're normal, then again, are we looking at subclinical hyperthyroidism? Are we looking at something else? And in the case of Graves' disease, you almost always would want to order these anti-TSH receptor antibodies, which confirm your diagnosis of Graves' disease. The step that is unique to the evaluation of hyperthyroidism is to also follow up with radioactive iodine nuclear scans. So what is a radioactive iodine uptake scan? So remember, iodine is important for the synthesis of thyroid hormone, right? So if you give someone radio-labeled iodine molecules, iodine-131, that can be seen in these nuclear medicine scans, right? Then the areas that light up are going to be areas that are taking up a lot of this iodine, that are producing a lot of thyroid hormone. And so, like you remember the picture of the thyroid gland, it sort of looks like a butterfly right there. This is what your normal thyroid gland would look like, right? There's some level of activity. At any given moment, your thyroid gland is producing thyroid hormone, so it's taking up these iodine molecules, and it's taking up some of these radioactive iodine molecules, so you can actually see it when you do the imaging. In Graves' disease, basically because you have these stimuli, these antibodies that are telling the thyroid hormone to make more thyroid, telling the thyroid gland to make more thyroid hormone, you see basically symmetric and just diffuse increased activity across the thyroid gland. Your entire thyroid is on high production levels, right? Wartime production. It's like, let's go, let's make some thyroid hormone. Toxic multinodular goiter, again, you see these small areas of focus that are producing more, but not symmetric across the thyroid gland. And then a toxic adenoma, there's just one area that's an adenoma. Now, I mean, it may look like this is a very large adenoma, but compared to the rest of the thyroid gland, it's just one small area that's overproducing thyroid hormone. So the radioactive iodine uptake scans really also tell you a lot about the process for what's going on here. Why is this important? Because the treatments sort of are dependent on what etiology of disease you have. For Graves' disease may spontaneously remit given enough time and symptom management. So it is reasonable to start someone on medications and monitor them in the process of getting them referred to an endocrinologist. For toxic multinodular goiter and toxic adenomas, these are unlikely to resolve on their own, and they usually require some kind of a surgical treatment. Now, surgical treatment could be ablation of that adenoma or ablation of the thyroid gland, or actual surgery with a scalpel. And these treatments, what's important to know is that when you treat someone for hyperthyroidism, you're effectively destroying the thyroid gland. You're effectively saying, okay, there's too much thyroid hormone, we've got to basically level everything. And you make patients effectively hypothyroid, so that in the future they are dependent on getting thyroid hormone replacement. So there's some, you don't necessarily want to jump through these treatment processes and make someone hypothyroid, effectively saying that they need to be on thyroid replacement for the rest of their lives, unless you're sure of what the diagnosis is. Again, when you get to this level, you're sending someone to an endocrinologist or a surgeon, basically. Any questions? I'm mindful of the time here, and I'm trying to see if we can get through these by the hour. So thyroiditis, subacute thyroiditis, is usually a viral infection that causes some destruction of thyroid follicular cells, thereby releasing thyroid hormone. When you do a scan, it'll show low uptake overall because you're not actually producing more, you're releasing thyroid hormone from cells that are basically being infected and inflamed. Which is why you'll have an initial period of hyperthyroidism followed by hypothyroidism once the thyroid hormone is repleted, and then a return to normal. This is important to know because if someone comes in randomly and they have certain symptoms, fever, painful kind of tenderness in the thyroid gland, their thyroid hormones are abnormal, you may want to follow them because this may be a case of a viral infection or inflammation of the thyroid gland, thyroiditis. So that slide should have probably been later because going back a little bit, talking about the treatments for hyperthyroidism, and this is important to know. Methimazole and propylthiouracil, or PTU, are the two medications that are approved for hyperthyroid treatment. And basically what they do is they inhibit the synthesis and production of thyroid hormone. It takes a few weeks for these medications to work. So if someone comes in with Graves' disease, you start them on low doses of medication and monitor their TSH, monitor their thyroid hormone levels to see them coming down. Methimazole is usually first line. PTU is safer in first trimester of pregnancy, and also prevents conversion of T4 to T3. So it can be used in hospital settings. When you get pregnant patients with thyroid dysfunction, with hyperthyroidism, these are people that you would be wanting to send to an endocrinologist and make sure that you have them on the right medication. Both of these medications can be toxic. So this is very important to know. Methimazole especially can cause immunosuppression, so a drop in your white blood cell count, and hepatitis or elevated liver enzymes. So you need to be monitoring these patients pretty carefully, as opposed to levothyroxine, which is a pretty benign medication in terms of other side effects. You just really have to worry about overshooting your thyroid levels. These medications for the treatment of hyperthyroidism can be toxic. Other treatments, beta blockers, propranolol in particular, is one of the mainstays of treatment for hyperthyroidism, and this is just symptom control. Decrease their tachycardia, decrease the tremor, try and decrease that adrenergic surge that these hyperthyroid patients feel. Corticosteroids sometimes inhibit conversion of T4 to T3. Don't often use those in the initial treatment, but it's important to know. And then referral to endocrinology. Most of these patients should be referred to an endocrinologist. Yes?
So, will they have to take this forever?
Good question.
Because now their levels are gonna look normal, so you're like, I don't know.
Good question. So with Graves' disease, patients can be managed on methimazole for a period of time, months to years, and it may spontaneously remit. They may normalize on their own without needing further surgery. So,
But how do you know that if their levels are already regulated because of those?
yes, close monitoring, right? When someone is hyperthyroid, if you put them on, similarly to thyroid replacement, you're going to have to put them on a dose, recheck their thyroid hormone levels or TSH in, 2 to 6 weeks, let's say, depending on their symptoms. You're going to follow up. If everything is normalized, then you're just going to be kind of following them up every few months, thyroid hormone levels, CBC and liver enzymes. And you could do that for many years if they're normal. At the point at which you start seeing, okay, now they're starting to dip too far, too low, then it's reasonable to stop the medication, do another thyroid uptake scan and see what you see, right? When they're off the methimazole, and see, are they still taking up a lot of thyroid hormone? Do they still have positive antibodies? In the case of Graves' disease, if they have, like I said, if they have that adenoma or a toxic multinodular goiter, you're not really, if they have no access to surgery or anything like that, let's say they're completely uninsured, then you're just going to be forced to give them antithyroid treatments for the extended period of time and hope that they do okay. But that's a good question. So these patients should not be treated indefinitely, right? They should be referred for a definitive kind of treatment. Make sense?
Mm-hmm.
Okay. So the patient that I mentioned ended up having Graves' disease. Interestingly enough, he also had a concurrent schizophrenic psychotic disorder. So it made his diagnosis very difficult to figure out. Plus, he was uninsured, so there was a real delay in getting him care. He did end up going to the hospital several times for thyroid storm. And in the setting of severe hyperthyroidism, patients can develop end organ damage. When your thyroid levels are that high, fevers, tremors, heart failure from the strain of the tachycardia and cardiac changes, liver failure, delirium and psychosis is what you tend to see, is this altered mental status. And these patients can die. And this is identifying, first of all, who your hyperthyroid patients are. And if you're seeing any of these signs, particularly altered mental status, to the point where they're experiencing delirium, their level of consciousness is altered, and these people need to go to the hospital, and they can be treated with intravenous PTU. They can be normalized much more rapidly and just given symptomatic treatment. And this is a clinical diagnosis. So, if you saw that patient with the bulging eyes, the exophthalmos, and you said, okay, this is a patient that really appears to be presenting with hyperthyroidism, and you were really concerned about additional findings that were potentially life-threatening, then you'd have to make sure that you send this person to the ER for evaluation. tiny little break.
Mrs. Oliver?
Yes, my dear. What's the trouble? Are you all right?
Yes. Yeah.
It's my goiter, isn't it?
Did you say goiter? What goiter?
This football-shaped lump jutting out the side of my neck.
Oh! That goiter. Hey! What do you know?
Does it bother you?
Bother me? Oh! Why would a little goiter like that bother me? No, not a bit. It's nothing. It's nothing. In fact, it's very distinctive, you know. I mean, you want to know something? I wish I had one. Really?
Right. I'm going to try and break up the monotony a little bit by just random videos every once in a while. I'm sure none of us really would wish to have a goiter. So a goiter is just a generic term for really any swelling of the thyroid gland. I should have had a picture rather than just a vague description from a Seinfeld clip. But you know, it's obviously when you see patients with true goiter, there's distinct swelling in the thyroid gland. It can be asymmetric, it can be one side or the other. And it's just diffuse swelling of the gland and or presence of nodules. Rare presentation in the US because we're diagnosing people earlier. We're not usually letting people proceed with hypothyroid or hyperthyroid symptoms to the point where they develop a thyroid. They're usually caught in our health system. But these people can be hyper or hypothyroid. If they have Graves' disease and they have overproduction of the thyroid gland, they can be hyper. In the same way, when you have a deficiency of iodine and your body, your thyroid gland is basically trying to compensate for that by producing more thyroid cells, but you just don't have enough iodine to make those hormones, then you can also develop a goiter. Thyroid nodules are focal areas in the thyroid gland. They can be what are called hot or toxic, which mean that they produce thyroid hormone, or cold, which means they're non-functioning. And you know, that's an ultrasound diagnosis. Ultrasound is pretty good at picking up these findings on a thyroid gland. Either of these could be thyroid cancer. We haven't talked about thyroid cancer. That's probably a discussion for a cancer lecture. But it's important to think about thyroid cancer as on your differential diagnosis. If you don't ever end up feeling a thyroid gland or goiter or nodules on an exam, you know, it's very difficult to do. You know, we've sort of lost a lot of our ability as a profession to do a great clinical exam. Also, I think, you know, the sensitivity and specificity of people actually feeling thyroid nodules is pretty low. Ultrasound is very good at finding these things, so I think it's important to try, but you know, I've rarely been able to feel thyroid nodules or you know, swelling in thyroid glands like goiters unless it's very prominent. But an overall physical exam is still very important, right? You can see subtle tremors, you can see hyperactivity or anxiety on exam when someone just is very restless, and those kinds of things you can pick up on. And exophthalmos. So exophthalmos is that basically projection of the eyeballs out of the eye sockets, and that's a finding in Graves' disease. That's not related to actual thyroid hormone problems. It's a result of the antibodies attacking the intraocular muscles of the eye. So basically, what you'll notice is that when patients try and close their eyes, they may not completely close their eyes. There may be a little bit of white still left. So that's an important finding to be aware of. Thyroid disease in pregnancy, very important to know about. All pregnant women are screened with a TSH due to the effects of low thyroid on the development of the fetus. For the purpose of brain development in the fetus, thyroid hormone is extremely important. And like I mentioned before, iodine deficiency, which causes a deficiency in thyroid hormone, is a leading cause of developmental delay in newborns, right? So that's why it's very important to screen for this. Subclinical hypothyroidism, we kind of talked a little bit about that. Postpartum thyroiditis, important to realize that after pregnancy, after delivery, some women, incidence of 5 to 15%, will develop this inflammation of the thyroid gland. And initially that, like I mentioned before, inflammation or thyroiditis will cause hyperthyroidism because you're releasing thyroid hormone, and eventually it may lead to hypothyroidism. Important to know, because when you see cases of postpartum depression, that's another case where it's useful to screen for thyroid hormone or TSH after delivery. Some of these women may need long-term thyroid replacement. Important to know primary versus secondary hyper and hypothyroidism. So there are rare cases where the problem is not the production of thyroid hormone, but the production of TSH. So if you're having a problem in the anterior pituitary and you're not producing TSH, then your TSH will be low when you screen for it, right? Because you're not producing it, and you're going to have a low thyroid state because your TSH is not stimulating your thyroid to produce thyroid hormone. So, like you mentioned before, when do you refer to endocrinology? If something is just not looking right, with you're trying to replace someone, their TSH is still low, or you think they're hyperthyroid, but they clearly have symptoms of hypothyroidism, again, referral to endocrinology, because it's important to know that there are some secondary causes. If the anterior pituitary does not produce enough TSH, then the thyroid will not be stimulated to produce thyroxine. And a couple of last-minute things to keep in mind. It's very important to know the drugs that interact with thyroid hormone production. Glucocorticoids, prednisone, steroids, they can have some effect. Iodine, we rarely treat people with iodine, but there are cases where the taking in too much iodine can lead to both hyperthyroidism, because your body's trying to produce thyroid hormone because it sees all this iodine, and hypothyroidism. And amiodarone is one of those drugs. Amiodarone and lithium are probably the two most common drugs that you'll see. Now, they're not super common, but amiodarone is used for the treatment. Does anybody know what amiodarone is used for? It's an antiarrhythmic, right? Very commonly used in the treatment of rhythm control and AFib. And it definitely interferes with iodine metabolism and can cause hypo or hyperthyroidism. And same with lithium. Lithium interferes with thyroid regulation. So patients that are on these two drugs, you just want to have red flags in your mind about being cognizant of monitoring their thyroid status. Again, rare causes of hyperthyroidism. There are patients that can have thyroid secreting tumors in other parts of their body. And then factitious. I put this on there. I tend to see a higher percentage of patients with mental health issues who may be overtaking their thyroid hormone. They may be taking it from another doctor. They may be seeing you and they have a psychiatrist or someone else that's giving them some kind of herbal supplement that includes thyroid hormone. And as a result of that, they may not tell you. They may be taking too much of it because, thyroid hormone, if you're obese or if you're hypothyroid and you're gaining weight, water retention or from your fatigue, then thyroid hormone will help you lose weight, right? So it's one of those things that people often are told by a naturalist, take this thyroid hormone supplement or whatever. So it's important to just, kind of keep that in the back of your mind if you feel like there's something unusual going on. Tried to finish before the hour, didn't quite make it. Any questions?
Is there a test for Hashimoto's?
Yes.
There's a paradox. There's an antibody. What's the test for Hashimoto's?
So you can test for the anti-thyroid peroxidase antibodies.
Oh, that's considered.
Yeah. So those are the antibodies produced in Hashimoto's thyroiditis. Yeah. Yes.
So, most likely we'll be dealing with the thyroid, but let's say the problem lies in the anterior pituitary. Would we most likely have already
It's an anterior pituitary problem. So I have not seen anyone come in with an anterior pituitary problem that presented itself as primarily a thyroid problem. You know, people can get pituitary gland tumors. There can be other drugs that affect that. You know, there can be certain conditions like postpartum hemorrhage can lead to infarctions of the pituitary and things like that. So usually it's in the setting of something else. But you know, if you're suspecting pituitary dysfunction, oftentimes people would get a brain MRI to see like what exactly is going on in the pituitary gland. Are there adenomas or whatever? And then you'd be referring them. Does that make sense?
Yes.
Yes.
Have you ever heard of a patient with Hashimoto's whose levels fluctuate monthly or are cyclical? I just had a patient tell me this, that she.
Yeah. You know, I mean, it's theoretically possible, right? When you have autoimmune diseases and there's, you know, if you're, you know, the autoantibodies that are causing destruction of the thyroid hormone, initially in Hashimoto's, like those other thyroiditis conditions, you can get an increase, like if you're catching someone right at the onset of Hashimoto's, you can actually see an increase in thyroid hormone levels, right? And before they start to drop. So these autoimmune disorders can have various time courses. I mean, I'm not sure if I would see like a purely cyclical kind of thing that goes over the course of years and years, but you know, it's theoretically possible, I guess. Anything else? All right, so I hope there's no similar errors in the diabetes slide.
I haven't seen
But if
any
you
of
do
these.
see anything, let me know.
Will do.
I checked the report, the average was 55%, and the national average is also about 55% on that prep exam.
so much better.
So that's,
So you get the big fail.
it's very normal, very normal.
Yeah. I took it and I got 52%, and
Yeah.
I thought,
You're right on
I don't
target.
deserve to be an NP. Oh,
Hey.
yeah, it did.
I'm sorry, normally I send out an email beforehand, like, don't worry when you see the results.
Well, I knew that there was gonna be some things that, you know, I'd never even heard of.
The other part of it is they tend to make this a little maybe more obscure than the actual exam is because they want to scare people into taking their prep course
Oh,
too.
there you go.
So,
That's neat.
yeah, smart but mean. So please don't worry, it's very normal.
Now, the one thing I had a question about was the blood pressure, the woman comes in 138/80. And they said, you know, she pre-hypertensive, normal, blah, 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 blah. Well, I thought the new normal was 140/90.
So,
So is that the old standard
that,
that
well,
they're
it's,
testing on, or-
that's what's considered or time for treatment is when it's above a certain level. But in
Okay.
terms of like an actual diagnosis of either pre or hypertension, you wouldn't, I would actually probably have that on my diagnosis list or my problem list as something to be able to track. So yeah, you wouldn't necessarily be treating. Although the new study they just put out shows that if the difference in adverse problems down the road, if somebody's at 130 or 140 versus 120, the 120 has way better outcomes. So
Sure.
it's always
That
evolving.
makes sense, you know,
It's-
but
yeah,
I
it's
just-
always evolving, but
I
then you
thought-
might see the next time these guidelines come out, they're going to be saying, oh no, we do need to start treating a little bit more strictly. But
Okay.
for now, the
Okay. I
guidelines.
thought I had that answer because I'm like, they're trying to trick you,
Yeah.
because it was the old standard, but.
Yeah. Well, you have to be careful of the wording. Is it like, are you going to treat or are you going to diagnose?
Right.
And so
Right.
yeah. So it's,
Those pre-hypertensive was that was right answer. Yeah.
Oh, you put,
I put normal because I was looking at that 140 number.
All right.
It went
Okay.
back down to 120.
Should we go ahead and get started here? So we have until 12. So if it's okay with you guys, maybe we'll just kind of push through the rest of the time because this is, you know, the lecture on diabetes obviously is, there's way more information that I can hope to cover in this time period. There are some comments from the last time I did this were that I spent very little time on the actual treatment, right? Like talking about all the medications, talking about insulin, those kind of things. And there's a reason for that, but I did include a lot of reference material in the slides, specifically on the newest medication, little flashcards with all the medication, oral medications, injectable medications. And I'm not going to spend a lot of time, again, going through those, just to show you where they are on the slides so that you can reference them later. There's also a really good reference at the end of my slides. There's a link to the diabetes, the ADA, the American Diabetes Association, standards of care guidelines. That's a really great little document to read because it basically goes over a lot of what I've gone through in terms of management, treatment, screening guidelines, and those are probably even more up to date. I think that came out in December 2016. So if there's anything on my slides that's a little bit out of date, then just refer to those documents, okay? I'm going to be focusing primarily on talking about the pathology, the pathophysiology, and sort of like a global clinical understanding of what diabetes is, okay? There are going to be some videos like in there to kind of like give you guys a little mental break as well, so hopefully that will help in terms of going through the whole thing. And again, ask questions anytime, just raise your hand and we could stop the slides. So outline a little bit of the introduction and history of diabetes, the epidemiology, the pathophysiology, major complications of diabetes, why do we care about diabetes, that's what this is really about, diagnosis, and then management and treatment, like I mentioned, in terms of talking about medications and things like that, we're going to gloss over that pretty quickly. At the very end, I'm going to talk briefly about special cases that you need to be aware of and that you can research more later. The vast majority of what we're going to be talking about today is adult type 2 diabetes, or adult non-insulin dependent diabetes as they call it. Okay. Lightning bolt, important primary care concepts. And anytime you see this book on a slide, those are slides that you should probably maybe print out for later and just keep a record of those medication lists, etc. Okay? So, an introduction and history of diabetes. So diabetes, what the word diabetes actually means to pass through, or some people used to translate it as urination, but actually the Latin is to pass through. And mellitus means sweet. When diabetes was discovered as a disease entity in ancient times, there's anecdotes from ancient Greek and Indian physicians who described this very terrible, fatal illness where people would come in and basically just urinate themselves to death, basically, by dehydration and other symptoms. There was no cure. There were some attempts at treatment with herbal remedies, but it was essentially a fatal illness. In 1921, Banting and Best actually discovered what the pathophysiology was, which is they were able to induce and reverse diabetes in dogs by extracting insulin. So now we know that insulin, that the primary driver of diabetes is somehow related to insulin. What diabetes actually is a disorder of glucose storage and metabolism. Anyone know who this is? Halle Berry, yes. Storm, but the actual person, Halle Berry. Halle Berry is a known diabetic. I believe she's a type 1 diabetic, if I'm not mistaken. And I bring her up because when I was in medical school at UCSD, the person who gave the endocrine lecture, the diabetes lecture, treated Halle Berry. Apparently he was her diabetes doctor and would never fail to bring her up in conversation throughout the lecture. So as an homage to him, there's Halle Berry. So as we know, diabetes is an epidemic, right? Currently, these numbers are from 2014. 29.1 million Americans, or 9.3% of the population, has diabetes. That's a diagnosed number of 20 million, and presumably a large undiagnosed population of about 8 million. 1.25 million of these have type 1 diabetes, or what they call juvenile onset diabetes, or insulin-dependent diabetes, which we'll talk about later. But the vast majority is type 2 diabetes. Diabetes is a leading cause of kidney failure, dialysis, non-traumatic lower limb amputation, and new cases of blindness among adults. So just let those 3 complications set in for a second. It's a major cause of heart disease and stroke, and attributed as the 7th leading cause of death. So, I don't need to beat the dead horse here, but we all know that diabetes is an epidemic of major proportions, and it's going to get worse. By 2050, the prevalence of total diabetes is expected to go up to about almost 1 in 3 adults. So the fact is that you're going to see a lot of diabetic patients in your clinic. Now, this is largely due to a couple of factors. We'll talk a little bit about the societal causes of diabetes, processed foods, etc. But the reason for the increase in prevalence is due to 3 things. The fact that the US population is aging, and as people get older, they tend to develop diabetes. The increasing size of higher risk minority populations, particularly Latino populations, are at high risk for diabetes, and declining mortality among those with diabetes. Diabetics are living longer now. We're able to manage these complications. If they're on dialysis, they stay on dialysis and they live. So when we talk about the prevalence, we're talking about the total number of people with diabetes in the population. And as people with diabetes live longer, that prevalence increases. So this is why this is such a huge public health issue. On an individual level, diabetes is a disorder of glucose storage and metabolism. That is when we're talking about an individual patient. When we're talking about society, on a societal level, the diabetes epidemic is a disorder of lifestyle, marketing, technological advances in food processing, and a whole host of other things. This is like just a brief political, social commentary that I'm making.
So, life cereal, delicious, crispy, and it's got a big name, And I know you want to associate it with health, but that's not fun. Joey? Okay, you know what, I got it. Look, there are sweeter cereals than this, but I kept thinking about, nostalgia. How you remember something in the past, and it feels good, but it's a little bit painful, like when you were a kid. And life, that's a scary word to anyone at any age. So how do we make it fun? Eat life by the bowlful. Little kid, big bowl, big spoon. Kids see the giant bowl of cereal and they smile because they didn't box it with it. And moms see it and they get this twinge of how little their kid still is, even though they have to deal with life. Get those two together in a market and I think we're going to sell some cereal. That's all I have.
Well, I think if you'd invite us into the rest of your company, we could build a Saturday morning TV show around the whole Quick Roads family.
In fact, it could be called the Quicker Roots family.
I like the bowlful, but I think it's kind of smart for regular folks. The irony.
Sure. Picture. Mamas. Parent.
Yeah. When I go back to Chicago, all they're going to hear is a slogan. And I don't think this is going to cut it.
Well, why don't we let Don work that over? We can either talk on Monday if you're staying the weekend, or we can come see you in Chicago.
I got it, Pete. How about life is just a bowl of life cereal. Life is sweet. Enjoy the rest of your life. Cereal.
Don, they're not expecting you to do this right now.
Give me a second. Life. The reason to get out of bed in the morning. Life. The cure for the common breakfast. Life. Its sweetness never ends. Life. Eat it by the bowlful.
Oh, there you go. Cure for the common breakfast. Love it. It's got the health angle. Life makes you feel better. It's got protein. Really nice. That dog will want it.
Wonderful. We'll get that put together for you.
Should we discuss media?
And keep going.
I think we got a home run. We don't need to take up any more of your time. I know you have some celebrating to do. I don't know what to say. It's the most fun I ever had in New York.
Anytime, fellas.
Very good then.
Roger.
All right, nice little clip from Mad Men. Right, life cereal, healthy, full of protein, right? Pure carbohydrates, basically. So there's a lot of stuff in that clip just to sort of like explain how we got to this point of thinking that some of these things are actually healthy, and for kids nonetheless, when it's pure sugar and carbohydrate. So enough of that. So pathophysiology of diabetes, we'll talk about normal mechanisms of glucose regulation, specifically the hormones insulin and glucagon. And then we'll talk about negative feedback loops, again, like we talked about with thyroid, the regulation of homeostasis, or the being able to maintain a balance in your biological system. Negative feedback loops are really important in endocrinology for maintaining homeostasis. How do things go wrong in general with type 2 diabetes? You know, you could say it starts with lifestyle, diet, exercise, or lack thereof. Compounding that with obesity, increased fat stores, adipose tissue, hyperglycemia, and then genetic factors are very important. Those all lead to what we call insulin resistance, which then feeds back on this cycle. This slide you can refer to later, but we'll go through in more detail. We'll see how this happens on an organ system level in an individual person, then during the course of a day, and then during the course of a lifetime. So let's just start by looking at this negative feedback regulatory mechanism. You've got your two hormones, which are insulin and glucagon, that act in opposition to each other. Let's start down here, okay? Let's say at any given moment, your blood sugar is starting to drop, okay? Your low blood sugar. You're stimulating your pancreas to release glucagon. Glucagon is the hormone that says, hey, there's too little sugar, we need to bump that up. Acts on the liver to release glucose from your storage sites in the liver, primarily in the liver. Glucose is stored as glycogen in the liver. So when glucagon comes and acts on it, your glycogen stores are converted into glucose, and glucose is released into the blood, and blood sugar is raised, and that goes to the brain, to the muscles, wherever sugar needs to go, wherever glucose needs to go to act as your primary source of fuel, right? Glucose is your primary source of fuel for the brain and for muscles and other tissue. What happens? So now your blood sugar is high, and let's say it gets to the point where your body is starting to say, okay, your blood sugar is a little bit too high. That stimulates your pancreas to release insulin. So what does insulin do? Insulin promotes glucose uptake from the blood into tissue cells, muscle and other tissue cells, right? And that stimulates the lowering of blood sugar, and also it promotes formation of glycogen from glucose. So again, you're converting this back into the storage molecule in the liver. So this is a cycle that repeats itself on a minute-by-minute basis in your body to maintain sugar levels at a normal level. What does this actually look like during the course of a day, right? So on the top here, these are your insulin levels. These are your glucose levels. And then these arrows represent, like, let's say when you eat breakfast. So you eat breakfast, let's say 8 o'clock, right? As a result of eating breakfast, and we'll talk about this later, but carbohydrates and sugars are absorbed in your intestines and then absorbed into the bloodstream. So your glucose levels will rise. In response to that, your insulin levels will also rise in order to maintain glucose levels that are normal, right? To get that glucose to where it needs to go, first of all, right? Glucose circulating in the blood does not do anything for our system. It needs to go to brain tissue, it needs to get into the muscles and other cellular tissues where glucose is converted into energy, right? I'm not sure how far back you guys have had the physiology lectures on energy metabolism and glucose production, the citric acid cycle, all those kinds of things, but we're going to gloss over that and just say glucose is converted into the building the sugar, the energy molecules for cellular metabolism, right? So again, your insulin level goes up, and in response to that, your glucose levels will go down. Then you have lunch. Again, after lunch, your sugar goes up, insulin levels go up, and then your glucose levels, in response to those, insulin levels going down. And then your insulin levels decrease as well, right? Because once your sugar drops, you don't need to be pumping out insulin. Your body always has a basal level of insulin, right? It's not zero. There's some degree of insulin circulating in your body at any given moment. And then again for dinner, the same thing happens. Sugar levels go up, insulin levels respond to that, and maintain a relatively stable level of basal glucose, right? So now, if you are a healthy eater, okay, let's say you're not eating 3 times a day, but you're eating a lot of low carb, high protein snacks throughout the day, like they recommend you to do. This is what your insulin and glucose curves will look like, right? You have your baseline glucose is here, right? You have to have a baseline level of glucose in your body at all times. Somewhere around 70 milligrams per deciliter is your baseline glucose level. Response to a meal, it goes up, and again, your insulin goes up in response to that. And you're eating frequently, so your insulin is sort of responding appropriately to the fluctuations in sugar to kind of try and maintain as close to a level of homeostasis as possible. Now, of course, no one eats like that in reality, right? This is what we're actually doing, right? I left home and I didn't have orange juice, but I had a cup of coffee or a mocha, right? Which has probably a lot of sugar. And instead of a low sugar meal, it's a pretty high sugar meal, right? So my glucose levels spike up, and then I'm driving, so I drink my coffee, then I get here, I'm like, oh, I need some carbs, right? So I have a bagel. Again, all carbs, high glucose, glucogenic kind of foods. And in response to that, my insulin levels have to keep up, right? So my insulin levels are going up as well. You know, you have a hamburger, and what really drives this up is probably the soft drink, right? The high sugar sodas. So again, my sugars go up. Here's a candy bar, and then here's my dinner time meal, right? Let's say pasta and a piece of cheesecake at the end. So you can see, in order to compensate for these glucose levels, you obviously have to bump up your insulin production as well. Now, it'd be one thing if this were like an occasional day, right? Like I'm on vacation, fine. I have this kind of diet, and then when I go back home, I'm eating normally. But if that was my routine on a daily basis, right? Now we're looking at a time course in terms of years, instead of a single day. Let's look at this graph first right here. Remember, your baseline glucose level is what we'd call your fasting glucose, okay? This is if you have no food for 8 to 12 hours, let's say. Your sugar levels, based on that insulin-glucagon regulatory mechanism, should maintain themselves at a certain steady state, right? So this is my baseline glucose. Now my postprandial, or what post-meal glucose levels, are going to be high, right? If I drew an average, you know, you're probably going through like somewhere around here. So those are high postprandial levels. So my fasting glucose level is around here. My postprandial glucose is around here. If I'm doing that day in and day out for years and years, you're noticing my postprandial levels are going up and up. And not only that, but my fasting plasma glucose levels are going up as well. Why is that? Because my insulin levels are going up in order to compensate, and I'm developing insulin resistance at the same time. So if I'm developing insulin resistance, my insulin is not doing the same job, therefore my baseline glucose levels are going up, right? So you can see they're continuing to trend up. They cross a certain threshold, and now if I continue on that trajectory, they're going to spiral out of control. And the reason for that is that at some point, my pancreas says, you know what, this is ridiculous, I've had enough. Your body is resistant to insulin. Your pancreas is trying to churn out all this insulin. And at some point, you're going to notice a drop in the amount of insulin that you're producing, because your beta cells are saying, you know, I can't keep up. And at the point that you get beta cell failure, your insulin levels start to drop below levels in a normal person, and eventually may go down to significantly lower levels. Now, if your insulin drops, if that compensate, you know, that regulatory mechanism, if one leg of that mechanism is being taken away, now you're going to notice a dramatic increase in your fasting plasma glucose and your postprandial glucose, because there's not enough insulin to keep those numbers down, right? So this is what happens over the span of, this is how a single day, you know, in the life of someone who's got certain lifestyle conditions can lead to the development of type 2 diabetes over the course of years. Does this make sense? I think these are really important concepts to understand, because type 2 diabetes is a disorder that occurs over the span of many years, right? It's not necessarily something that's going to happen right away. It's taken a long time to develop. So we want to really try and find these people that are over here before their insulin levels start to crash, so that we can actually make some changes. Let's see. Oh yeah, forgot. So this slide is very busy, but this sort of encapsulates what we were talking about, right? Hyperglycemia, that's what we're ending up with. We're ending up with high blood sugars, and we'll talk about why that matters in a second. But as your pancreatic insulin secretion goes down, your glucagon secretion goes up, you're leading to hyperglycemia, you're not taking as much glucose in your cells, in your muscle tissues, your liver is producing too much glucose as well. Remember, because when you don't have enough insulin, your regulatory compensation is glucagon, and so then your balance is out of whack, right? So there's too much glucagon relative to the amount of insulin you have. So glucagon stimulates hepatic glucose production, gets that glycogen converted to glucose. So there's all these things that are contributing to hyperglycemia. And of course, your carbohydrates are absorbed in your intestinal tract. That leads to high sugars. And then the brain. What does the brain actually contribute to this whole process, right? We'll talk about that a little bit later. So why does it matter that you have high blood sugars? Well, high blood sugars or hyperglycemia in and of itself is bad for your body, but it also contributes to a whole host of downstream effects. And these are really the primary drivers of morbidity in diabetes. Just having high blood sugar at any given moment, it may cause certain symptoms, but the lifetime accumulation of high blood sugar is what leads to these complications downstream. So let's talk about hyperglycemia. Often this is what leads to our diagnosis, right? Now, in theory, you'd see someone coming into your clinic and they'd say, oh, I'm feeling really tired and fatigued. I feel like I'm drinking a lot of water. I'm urinating all the time. I'm eating a lot of time. I'm hungry. I notice some blurry vision. These are your classic symptoms of hyperglycemia, right? Why are you peeing a lot? Well, the osmotic results of high sugar in your blood lead to glucose spilling out into your kidneys, into your urine, and water following that, right? It's basically an osmotic process. So when sugar is filtered out into the urine and the kidneys, you're going to lose water along with that. And if your sugars are really high and you're losing a lot of sugar in your urine, you're going to be losing just as much water, and you're going to basically be unable to compensate. We'll talk about DKA, but this, as you can see, why initially when people talked about diabetes and urine passing through or water passing through their body, this is what the initial state looks like. Nowadays, because we're aggressively screening, depending on the setting that you're at, you may not see people with true hyperglycemia. You will see a few of these patients, but a lot of times we're catching these people earlier before we get these true symptoms. But in type 1, this is how often type 1 diabetics present, or even more seriously. Let's see. That slide doesn't seem to be showing up for some reason. So this slide basically just talks about hyperglycemic states, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome. I think, there we go. That's weird. So, if our sugars remain high and we don't do anything about it, we can get to this state called diabetic ketoacidosis. So this is what you see, or this is what the ancient physicians would see when people were dying of diabetes, right? What happens if you have an absolute deficiency in insulin? And we normally see diabetic ketoacidosis in type 1 diabetics. I'll talk about that later, but just know that type 1 diabetes is an absolute disorder of insulin, right? So when you hit that end of the curve on the time scale where your insulin levels are going down to 0, that's what type 1 diabetes looks like. Diabetic ketoacidosis, if you have 0 insulin and your sugars continue to skyrocket out of control, you continue to get dehydrated, you can end up in this state called diabetic ketoacidosis. Very important to know what this is and what this looks like. Symptoms, classically people present with abdominal pain, which is not really clear exactly why, maybe just from profound dehydration and electrolyte abnormalities, nausea and vomiting, fatigue, weight loss primarily due to profound dehydration, blurry vision like we saw before, polyuria, polydipsia. And this blurry vision is actually because of high sugar, the osmotic effects of high sugar in the lens of the eye. I'm not sure exactly the physiology. This is different. It's important to know this is different from the end results of diabetic retinopathy, for example. This is very transient when people notice they're having blurry vision due to hyperglycemic states. So diabetic ketoacidosis, like its name implies, means that you have diabetes, the production of ketones, and acidosis. And this is a medical emergency and needs to be treated in the hospital. So why do you get diabetic ketoacidosis? So you've got no insulin, right? And what happens when you have a lot of sugar circulating in your body, but no insulin? It's kind of like that poem, The Rime of the Ancient Mariner, like water, water everywhere, but no drop to drink, nor any drop to drink, right? There's sugar circulating in your blood, but your muscles are not seeing any of this sugar. Your brain is seeing some of it, but overall your body thinks, I've got no sugar because it's not getting into my muscles. I'm profoundly fatigued because I'm not getting the fuel I need to make my body run. Well, when that happens, your body has a mechanism for getting fuel, particularly to your brain where it needs it, right? And that's to say, okay, we've got no sugar, we've got no fuel, let's start breaking down fat cells into fatty acid and glycerol, and then these fatty acids are converted to ketone bodies. Ketone bodies are a short-term formulation of fuel that is responsible for brain function, that can help the brain survive, because the brain is absolutely dependent on fuel, on glucose. And we'll talk about this with hypoglycemia later. Also, your liver is saying, okay, there's not enough sugar, so I'm going to produce more sugar, right? So your liver is pumping out more glucose into the bloodstream, even though there's plenty of sugar in the bloodstream, it's just not getting to where it needs to go. When you get these ketones produced, ketones are essentially acid, so you're getting acidosis of your blood. Does this make sense so far? This is pretty complicated stuff, but so what's important to understand is that in the complete absence of insulin, your body is saying, okay, I need another form of fuel. It's going to produce ketones from breaking down these products, and ketones are acids. So now you've got the diabetes aspect. You've got high sugars and dehydration, so your body's profoundly dehydrated. You've got ketosis, so production of these ketones, which in and of itself is not dangerous because your body thinks it needs this fuel, but ketones are acids, so you get acidosis of your bloodstream. And acidosis is profoundly damaging to enzymes and to cells, right? As your body kind of overwhelms its ability to maintain acid-base balance, and you start getting acidosis, you get dysfunction of enzymes, you get electrolyte abnormalities, because one way to regulate acid is to exchange it for potassium in the cells. So what you do is you actually get a profound hypokalemia, even though it appears that your blood potassium levels are high in order to compensate. So it's really confusing, but eventually those potassium levels will cause arrhythmias and death. So these are the three basically pillars of diabetic ketoacidosis. It's so weird that some of these slides are not showing up. I wonder if there's a way to
Is it just a regular slide or are there images or something?
no, there's no images, just random. So I'll tell you what this slide says. It's not a whole lot there. The treatment of diabetic ketoacidosis is 4 things, and it's all in the hospital. But it's important for you to know, right? If you're dehydrated, you need fluids. So fluid resuscitation is the #1 thing. insulin, right? Your sugars are high, you have an absolute deficiency of insulin. So you need to get insulin into your system as soon as possible to drive those sugars down and to reverse the baseline process that's going on. Bicarbonate, now if you're profoundly acidotic, you need to reverse the acidosis as well. So usually these patients need bicarb and potassium. Interestingly, this is one of the things about diabetic ketoacidosis. It's kind of like a test question. You see patients come in and their potassium levels are high, right? In the serum, their potassium levels are high. Once you start reversing their sugar issues and their metabolic issues with insulin and fluids, those potassium levels will crash because they've actually lost a lot of potassium in the dehydration process. So you're going to need to get people started on potassium pretty soon after they're admitted for DKA. I'm sorry that this slide isn't showing up. I hope that that's not the case with too many more slides. So remember, DKA is what you see in type 1 diabetics. There's an equivalent sort of state which is called hyperosmolar non-ketotic hyperglycemia, where there's still usually enough insulin to prevent the ketone and acidosis production, but you still get the profound dehydration. You still get type 2 diabetics that have very little insulin, maybe enough though to prevent that, but they're still getting profoundly dehydrated. These are people that are often very ill, brittle diabetics. They've got a lot of other comorbidities. And when you see people that are continuously going into the hospital with these hyperglycemic states, it's a very bad sign. And a little note here, type 2 diabetics who are highly insulin dependent can present in DKA. Classically, they'll say, well, DKA is only what you see in type 1s. But as we're seeing more and more of these patients that have very little insulin, some of them will present with ketones and acidosis, and it's something that you'll have to know. Any questions about DKA? Okay. So, like I mentioned before, the rest of the complications of diabetes are numerous, right? Cardiovascular disease or macrovascular disease. Let's see if I can fix this here. Okay. I have to go without my notes. This slide, lightning bolt, I'm not going to go spend too much time on it, but it's very important to know the factors that contribute to cardiometabolic risk, your overall risk of cardiovascular disease. We're talking about macrovascular, big blood vessel cardiovascular disease, or what's sometimes called atherosclerotic cardiovascular disease, right? The diseases that lead to blockages of coronary arteries and coronary artery disease, angina, myocardial infarction, and strokes, CVAs, TIAs, and also peripheral arterial disease, which is blockages in the peripheral arteries leading to claudication and lack of circulation in the extremities. So those are the three big macrovascular disorders. And this slide basically says there's a lot of things that contribute to that, right? Family history, inflammation, hypertension, smoking is a big one. Insulin resistance and hyperglycemia, elevated glucose, it's more complicated than just high sugars. There's this whole syndrome that contributes to your cardiometabolic risk, as well as lipid metabolism. And then obesity is an independent risk factor as well. So diabetes is one of those aspects. We'll talk more about this at the end of the lecture. The microvascular complications are unique to diabetes, though, to high sugar circulating in the blood. And so there's this idea, this unitary hypothesis of diabetic microangiopathy, which is to say that anytime, any organ system where there's small, tiny little blood vessels that are very important to carrying out the function of that organ system, these organ systems are going to be susceptible to diabetes, okay? And it primarily shows up in three systems, in the eyes and the retina, because your retina is basically a film of very, very tiny blood vessels on which are superimposed, all your rods and cones and your cells for light processing. Your kidney, right? Your kidney, the functional unit of the kidney is the glomerulus, which is again this ball of very small capillary-sized blood vessels. And then neurons, or peripheral nerves. So peripheral nerves, especially your longer peripheral nerves, they're still nerve cells, right? They have to be supplied by blood in order to get nutrients, oxygen, etc. So your long peripheral nerves are also particularly sensitive to the effects of microvascular disease, because if these tiny blood vessels are not being able to supply these long nerves, then those nerves are going to die. So neuropathy, retinopathy, nephropathy, again, these are highly dependent on small vessels. The underlying cause is the same, is that sugar circulating in the blood causes damage to the inner lining of these blood cells, leading to damage. The higher the blood sugar, the worse the disease is going to be. I'm going to start going through these slides pretty quickly, so please stop me if there's questions, okay? Neuropathy, most common complication, we're talking about a distal symmetric sensory polyneuropathy. Basically, what we see is that the nerves that are most affected are the longer nerves, particularly the ones going to your feet, right? Because those are the longest nerves in your body, and it's the sensory nerves that are most affected. I'm going to talk briefly about Charcot foot, because Charcot foot is a unique disease that is sometimes seen in diabetes. Has anyone seen Charcot foot? So this is what the bones of a normal foot look like, right? There's a nice arch, there's a good weight balance, and this is Charcot foot, where the bones just basically start to collapse on themselves. And then you'll see ulcers developing, you'll see these swollen, deformed feet. Why does this happen? This is a very complex process that leads to this, and it's actually very interesting. It starts with that sensory neuropathy, right? I mentioned before, initially you'll get pain. You'll get this burning neuropathic pain. Neuropathic pain is classically, the most distal, like in your toes, you'll feel a burning, tingling sensation, like if your foot goes to sleep, except much more, profoundly disturbing than that. Eventually, when the nerves completely die, you'll get complete loss of sensation. So the pain will actually lead to something not so bad. You just won't feel your foot. Well, that doesn't sound too bad, right? Until you start realizing that if you can't feel your foot, you're going to step on a nail, and you're not going to notice it until 12 weeks later when your foot is necrotic from infection, right? Or you'll fall asleep sitting next to a radiator and burn part of your ankle, and you're not going to notice it until you wake up and you have a huge burn, right? So that's what leads to these ulcers and infections. What's really interesting, though, is that at that point, it's not just your sensory nerves that die, it's your motor nerves, right? You have motor nerves that are responsible for the small muscles in your foot and your hands. In order to do, small movements with your hands and your feet, there's nerves that are innervating those muscles. When those nerves die, those muscles also atrophy. And when the muscles that are holding the architecture of your foot together start to atrophy and die, and you can't feel your foot, so you start getting injuries, you start getting small little fractures, your foot basically loses its integrity. It basically does not hold together. And you get these abnormal, the foot falls down, you get these protrusions of bone, then you're walking around on this bony prominence on the bottom of your foot without knowing it for weeks, and you develop this ulcer, this pressure ulcer. So when you get to the point of Charcot foot, you know that you've developed a very severe, extensive neuropathic disease, and this can lead to amputations, this can lead to worse consequences as well. So I just wanted to show you that. Retinopathy, again, there's 4 stages. Initially, the blood vessels, you get what's called a non-proliferative retinopathy. The blood vessels are just damaged. When that progresses, you get what's called a proliferative retinopathy, which is to say that at some point, your blood vessels are completely obstructed, and your retina is saying, okay, these highways are blocked, we need to start developing new highways, we need to start building. So you get proliferative retinopathy, which is to say that there's all these new blood vessels that are being formed because your body thinks that there's not enough blood vessels there to supply the retina. And when you do that, these blood vessels are not, adequately supplying the retina. If you get traffic jams throughout all the major highways, and then someone says, oh, I know how we're going to fix this. Let's just start building these dirt roads that can circumvent the traffic. That's not an adequate response, right? Those dirt roads are going to be bad to travel on. They're going to lead to further accidents. It's a pretty, I don't know if that's a very good analogy, but that's essentially what happens. And when you start seeing proliferative retinopathy, you're starting to get complications with your vision as well. And then nephropathy, again, those small blood vessels in the glomerulus will eventually start failing, and you'll start getting renal failure. One way of detecting that is microalbumin in the urine. As those cells start getting damaged and they start getting leaky, you'll start seeing increased levels of protein start to filter through. And so that's how we detect early signs of kidney damage. I'm going to talk a little bit about hypoglycemia. Hypoglycemia is not a complication of diabetes in and of itself. People talk about feeling, oh, my sugar is crashing, I'm getting low. Hypoglycemia in diabetics is a consequence of the treatment, either insulin or other medications that drive your sugar down. But hypoglycemia is much, much more profoundly dangerous than hyperglycemia at any given instant. And this is the most important thing to understand. Recently with the fires, I was helping out one of the shelters in Petaluma, and people were coming in, and there were a lot of insulin-dependent diabetics who were coming in saying, I don't have my insulin in the fire, my sugar is 200, 300. And a lot of people were saying, oh, we need to treat them with insulin. Let's give them some insulin and send them on their way. Bad idea, right? Because at any given moment, your sugar is 200 or 300, okay, that's not great, but that in and of itself is not going to lead to a profound consequence, unless you feel like you're developing, you're headed towards DKA, right? And that's, of course, important. You want to make sure someone's staying hydrated. But if you give someone insulin and send them on their way, and they don't have access to food and their sugar crashes, the brain is profoundly dependent on glucose. So when people go into hypoglycemic comas and they lose consciousness, and let's say they have had a long-acting insulin in their system, that can be fatal. So this is a very important point to understand. Okay, a lot to cover. Any questions so far? Wait 7 seconds, because that's usually how long it takes for someone to ask a question. All right. So we'll go on to diagnosis, and then we'll talk about management. So in the olden days, this is how they diagnosed diabetes, right? You'd collect someone's urine, you look at it, and potentially taste it. That's why it's diabetes mellitus, right? It's sweet urine. If your urine is sweet, normally you're not secreting sugar in your urine.
Who
So
tasted it? The person?
this
or the
guy.
doctor?
No, the doctor, of course. The doctor. Providers were very enterprising in the olden days. They make a lot of sacrifices,
I
which
still do that.
we don't do.
What?
Indigenous food.
Yeah. I mean, if you were,
Thank God for technology.
if you were in a rock and a hard place and you were trying to figure out, is someone have diabetes, this is what you'd have to do. But luckily we don't have to do that anymore. We can actually test the blood sugar for diabetes. Screening for diabetes, remember we talked about screening for thyroid disease, right? And how there's some controversy. There's no controversy about screening for diabetes. The general population should be screened for diabetes at least every 3 years starting at age 45. This is a pretty aggressive recommendation, but the converse is that if you don't think about doing some kind of screening test, you're going to miss that whole group of people who are undiagnosed with diabetes, and you're going to miss the opportunity to prevent the development of diabetes if you can detect prediabetes, right? So there's two categories that we need to know about: prediabetes and diabetes. Officially, there's 3 ways of classifying someone as a diabetic or prediabetic or normal, right? You get a fasting blood sugar or baseline blood sugar. This is usually they're fasting for 8 to 12 hours with no intake of sugar. And a normal fasting blood sugar is less than 100. Between 100 to 125 is what we call prediabetes, and over 126, it's sort of an arbitrary seeming number, but over 126, a fasting sugar of over 126 is a diagnosis of diabetes. Random blood glucose or oral glucose tolerance test, this is rarely done. This is done in pregnant women to primarily try and draw out those hidden pre-diabetics and those early diabetics. But for the most part, if you just come in on any given day and you check your blood sugar and it's over 200, you can be fairly assured that you're diabetic, okay? The pre-diabetes category for random blood sugar testing, I mean, this is not something to really hang your hat on. But the test that we now use primarily, which is the gold standard in my opinion, is the hemoglobin A1C. And I'll show you what the hemoglobin A1C measures in a second. But depending on your assay, depending on your lab may have slightly different numbers here. But for the most part, between 5.7, less than 5.7 is normal. Between 5.7 and 6.4 is prediabetes, and over 6.5% is diabetes. So what is a hemoglobin A1C? Hemoglobin A1C measures the amount of glucose that attaches itself to red blood cells as they circulate in the bloodstream. This cartoon, this is a little bit too cartoony. It didn't need to be this cartoony, I think. But
Dumb it down.
yeah, exactly. Yeah, this is not to offend anyone here, but red blood cells circulate in the body for about 120 days, right? So they're constantly produced and they're broken down. Over the course of a red blood cell's lifespan, depending on the amount of glucose that's circulating in the blood, these red blood cells will attach, will basically affix glucose molecules to them. And you can measure the percentage of glucose attachment to these red blood cells. So that's why the hemoglobin A1C is a great measure, because if a red blood cell circulates for about 120 days, then what you're seeing is a roughly 120-day average of what blood sugars have been. You know, at any given moment, your sugar might be low, it might be high, but if you can measure sort of 3-month average, this gives you a really good idea of what things have been like over the last 3 months. You know, conversely, like, you don't want to be measuring hemoglobin A1Cs on someone every day or every week, because you're not going to get much change unless you wait 3 to 6 months to see some changes. So initial interventions, we're talking about management here. These slides, anytime you see slides like this, they're from the American Diabetes Association. You can look these slides up yourself. It's very straightforward, but if you're impaired glucose tolerance, when they talk about IFG or IGT, these are kind of old terms, impaired fasting glucose, impaired glucose tolerance, but basically saying the same thing, they're pre-diabetic. Lifestyle intervention, follow-up, close follow-up, you know, plus or minus metformin, which we'll talk about. If you're diagnosed with diabetes, then you go down the pathway of treating diabetes. So what does that look like? So management and treatment of diabetes, lifestyle modification is one of those buzzwords that they always talk about. We'll talk about that in a second. People often think that management of diabetes is all about blood glucose control, and that's a big part of it. But you see, there's four bullet points here. Assessing and management of complications, those complications we talked about earlier, is just as important for diabetics. These are patients that you're going to be seeing for a long time, and it's the complications that are going to kill them or cause morbidity. So absolutely, in addition to focusing on blood glucose control, you got to be focusing on these complications. And you know, we talked about the microvascular complications, but overall, looking at their cardiovascular risk is also important. that's back to a time when Sesame Street used to be a little bit more blue, as opposed to like all Elmo and, you know, Smiley. There's a little dark there. But that's sort of like when we talk about lifestyle modification, we're like Captain Vegetable, right? Eat your vegetables. Don't eat spaghetti. Don't eat sugars. These are the official recommendations, right? Lose 7% of your body weight. Reduce calories and dietary fat. Blah, blah, blah. That's not as easy to do. You know, you can say this to a patient. You can bring out Captain Vegetable. How much of an impact is that going to have, right? But it's very important to understand that lifestyle modification is the underpinning of pre-diabetic treatment and early diabetes treatment, right? There's a lot of evidence-based studies to say what works with this. You know, intensive individual nutrition counseling is very important. We'll talk about diabetes as a team, a disease that requires a team-based approach. This is what comes from the ADA website. And I think if you had to like, you know like what are the official recommendations? These are the official recommendations, but it's a little bit more complicated than that. It really requires an intense team-based approach, individual nutrition counseling, classes, etc. You know, Captain Vegetable is not quite enough. I'm just going to quickly mention bariatric surgery because bariatric surgery is really one of the only evidence-based treatments for weight loss. And there's a lot of studies showing that, you know, significant weight loss can reverse diabetes, can cure, in a sense, your hyperglycemic states. So it's important to know about that. You know, people have different biases against bariatric surgery. I probably have a bias against it because a lot of the patients that I've seen have developed severe complications from some of these gastric bypass surgeries. You know, some of these lap band surgeries tend to not be as effective depending on who the patients that you choose. For some people, it's a miracle. You know, they lose all this weight and they do amazingly well. But so I just wanted to throw that out there. So blood glucose control, right? This is what we think about as being, okay, I want to learn about how to treat diabetes. This is what we got to know. And I'm going to go through these slides really fast because for two reasons. Between the time that I show you all these slides and the time that you're out in practice, let's say on your own, let's say that's a year from now or 2 years from now, there's going to be changes. There's new oral, there's new injectable medications approved all the time. When I was in medical school, the new medications were the thiazolidine diones, the Actos, the Avandia, that were hailed as, oh, this great new drug that increases your sensitivity to insulin. We don't use those very much anymore because of the cardiovascular complications, heart failure, edema. Those are the things that we're trying to avoid in diabetics. So what's the purpose of a medication that tends to increase your risk in that, right? So between the time that you're, you know, going through these slides and in practice, so many things will change that I think it's important to know some of these mechanisms and know the really important drugs and then just kind of know where to find this information. So going through these slides, you can see I've basically listed all the major classes. I'm going to talk about metformin, I'm going to talk about sulfonylureas, and a little bit about the rest of these medications. Yes?
Can I ask a question before you begin?
Yes.
For the A1C, what do you think about, both of you think about, so let's say the patient's 65 years old and their A1C is 6.5. My preceptor's kind of like, she uses they're 65 and their A1C is 6.5, I'm not really worried. If they're 75 and their A1C is 7.5, I'm not really, like, she's just kind of like age is her factor of, am I going to prescribe this or start this patient on something for diabetic control, or what are your thoughts on
Yes. Hold that thought.
Okay.
Hold that question. It's a very good question,
Okay.
and I'm going to get to another slide that talks about that.
Okay.
Any other questions? Okay, so let me go through. So metformin, if there's a couple of drugs you need to absolutely know about, metformin is the one that you absolutely need to know about. Metformin is I'm going to go down here. So metformin is what's called a biguanide. It's been around for a long time. It is a very good drug. It decreases hepatic glucose production. So going back to this slide here, metformin acts on this pathway. So reducing the amount of glucose that your liver is producing It also increases your peripheral tissue sensitivity to insulin. Metformin has been shown not to increase weight like a lot of the other medications, but actually be relatively weight neutral. It is the first line of therapy for diabetics and for prediabetes in some cases. Metformin has been shown, if you prescribe it to prediabetics, to prevent progression to full-blown diabetes. So very few contraindications for metformin. One thing that you got to know about metformin is that it's not tolerated very well in the GI tract. Nausea, diarrhea, upset stomach is the number one complication or side effect of metformin. Something to work through with your patients. Start with lower doses. There's an extended release formula that tends to reduce those side effects. There's an absolute contraindication for people with renal failure. This is another issue with metformin that's talked about. The older classes of these biguanides, when given in patients with renal failure, was shown to cause lactic acidosis, which is a profoundly serious complication. In all honesty, I have not seen a patient who's had renal problems that's been on metformin and has had lactic acidosis. I think it's mentioned as something to be very aware of, but I think in general, people should be on metformin, unless, I've seen some dialysis patients even on metformin because their nephrologists think that it's really important for them to maintain blood sugar control, and it's dialyzed out, so, they're on it. So, when people get IV contrast prior to, certain CT scans, et cetera, they're told to hold their metformin because the contrast can cause renal failure, et cetera, et cetera. How much of that is real versus just being overly cautious? I tend to think that people are being overly cautious, but again, it is very important to know that the official recommendations are restricting metformin in people with poor kidney function. Yes.
So I know providers, they'll put their patients on ACE inhibitors with metformin. You don't do that?
They don't?
No, they do.
Yeah.
You don't do you
No,
do
absolutely, yeah.
that? Okay.
Absolutely,
So
yeah.
is that for that reason,
It depends, it's pretty complicated when you're talking about renal function and ACE inhibitors, and because if there's two medications that you had to pick out of a box to give to your diabetic, it would be an ACE inhibitor and metformin, because ACE inhibitors protect the kidneys from the effects of diabetic nephropathy, and they lower blood pressure. They're shown to sort of increase your creatinine levels when you start taking it, so you have to monitor that, but if you're someone that's at risk for developing renal failure, then you need to be on a medication that has been shown to prevent that, right? So, it's a little bit of negotiating and a little bit of close monitoring, but there's no absolute reason not to put someone on ACE inhibitors and metformin.
Okay.
Does that make sense today? Yeah.
Yeah.
It's a little bit more complicated than that, but yeah, you shouldn't be overly concerned about using those medications. The next medication that I really want to touch on is our sulfonylureas. These are probably the next cheapest, next oldest medications, and basically what sulfonylureas do is it stimulates insulin release from the pancreas. So in order to drive sugars down, this person is already, the pancreas is already trying to produce insulin, but if you give them a medication that sort of helps boost that, then you can drive those sugars down a little bit easier. These medications are known to cause weight gain because anytime you stimulate insulin is a hormone that promotes weight gain, right? If you're pulling sugar into your muscles and your tissues, you're building up fat stores, you're building up glycogen. It's a pro-metabolic, it's a weight gaining medication. So sulfonylureas also cause weight gain. And what's really important to know is that sulfonylureas can cause hypoglycemia. Anytime you're stimulating insulin production, you can drive your sugars down too low. Metformin does not tend to cause hypoglycemia, whereas sulfonylureas, glipizide, glyburide, glimepiride, they do. And those work on this area right here. Let me see how much time we have. So 11:30. I'm going to talk briefly about some of these other medications, DPP-4 inhibitors. they act on other pathways. These are probably the next most useful oral medications. There's an interesting pathway here when we talk about the GI tract, right? When you eat food, there has to be some regulatory mechanism for saying, hey, there's going to be a bunch of food coming your way. Let's keep that in mind so that we don't let our sugars get out of control. Those hormones are called incretins. And incretins basically stimulate the release of insulin, and they inhibit the release of glucagon. So they're basically a way of saying to your body, hey, there's food coming in. Whatever our sugar state is right now, whatever our blood glucose state is right now, we're about to get a whole truckload of stuff. So let's anticipate that and start down-regulating sugar, our blood sugar levels. Does that make sense? So incretins are an important hormone, and there's various ways of attacking this pathway for treating diabetes. One way is there's an enzyme called DPP4 that in the body inactivates incretins, right? Everything needs to be regulated. So if you've got an enzyme that breaks down this molecule, if you have a medication that inhibits the inhibitor, you end up increasing the effect of these incretins, right? That's what DPP4 inhibitors are. They can lead to pancreatitis. That's one of the primary side effects. They can also lead to hypoglycemia, right? Anytime you're sort of increasing the mechanism of insulin release, you can lead to hypoglycemia. And the other, oops, I'm going backwards. I talked a little bit about the thiazolidinediones as a medication that these are a little bit older, and there have been recent warnings about adverse effects which have limited their use, right? Increased water retention, edema, heart failure. They're still used, but in my practice in particular, we're a lot more cautious, and a lot of insurance companies sort of don't like these medications to be quite used as much. I apologize for going really fast here. GLP-1 agonists, these are injectable that are basically mimicking incretins. So right, we have one medication that inhibits the inhibitor, and these are direct agonists. These are injections. They're only bioavailable as subcutaneous injections. Recently, Victoza or liraglutide has been shown to decrease cardiovascular events. So these are good medications as well. And the last one that I want to talk about, SGLT2 inhibitors, are probably the newest. And these basically increase your urinary excretion of sugar. So they're a way of lowering your blood sugar by excreting more of it in the urine. They've actually been shown to lower blood pressure as well, and are weight neutral or actually help you lose weight. Yes?
Can I just say something that I've seen that it's like a really, I guess, not very common side effect about the Invokana?
Yes.
I had a lady who was on it, and she kept having symptoms of a UTI, and she went to the urgent care, she went to the ER, and they were just kept giving her antibiotics, but nobody ever cultured her urine. So she came to us, and we did her urine, because she's like, I felt like, I have this bladder pain and stuff like that. And so we cultured her urine, and one of the side effects, because of the sugar coming out, is it's really irritating. So we ended up stopping her Invokana, but if anybody had tested her, cultured it before, they would have seen that she'd never had a UTI.
Yeah.
So she got all these antibiotics for no reason.
Yep. So that is the number one. I guess I didn't put it on here.
Don't they test glucose on a regular dipstick?
They tested.
Isn't that like part?
She did have glucose in it, but it wasn't like overwhelmingly high.
Well, you would expect it, since that's the mechanism.
Right.
Yeah. And this is the reason why these are also the primary limitations on the use. And I've seen a lot of people have those same symptoms: increased UTIs, candidal yeast infections, vaginal infections. For people who are overweight, for especially women who already have some urinary symptoms, either from bladder prolapse or whatever, these are just not good medications. But at the same time, they're effective at lowering A1C, they lower blood sugar, and they're weight neutral. So So yeah, thank you for bringing that up because that is a very common side effect of that medication. So we have to talk about insulin, right? So I'm going to spend a good amount of time talking about insulin because insulin is universally effective for treatment of diabetes. Unlimited dosing, right? Insulin is a natural hormone, natural occurring hormone. So there's no intrinsic side effects to insulin other than the effects of insulin itself, which is hypoglycemia and weight gain. When you get a patient to the point where they need insulin, insulin is really the only thing that's going to fix the issue. And it will fix the issue. It will reduce their blood sugars. It will get them back on track. When you get to that beta cell burnout, that phase on the curve where you're not producing insulin, you have to be on insulin. What's very important to know about insulin is a couple things. One, that there are multiple types of insulin, right? Based on how rapid their action is in the body and how long they last in your system. There's no difference between these type of insulins other than their duration of action and how quickly they're absorbed and they work, right? On one end, you've got Novolog or Humalog, which is a synthetic version of a rapid-acting insulin. When you inject it, within 10 to 15 minutes, it achieves its effect and peaks at about 60 to 90 minutes, and then it's out of your system, within a few hours. At the other end of the spectrum is Lantus or Levemir, which you inject once, and you get a long, basically curve. It basically stays in your system at a baseline level for a long period of time, up to 24 hours, sometimes even longer. So why do we have these different types of insulin, right? So think about it this way. One of the things that we want to try and do with insulin is recreate this insulin curve, right? You have a basal level of insulin in your body. So you need to have some medication that recreates that basal insulin level, right? At the same time, every time you eat and every time your sugar spikes, you need to have a short-acting type of insulin that will respond appropriately to that rise in sugar. So you can use something like Novolog or Lispro, those short-acting insulins, to recreate this curve. Your goal with insulin prescribing or insulin treatment is to do your best to try and recreate that curve. Now, if you were going to do this and you have someone that's actually eating 3 regular meals a day, you can see this would be, one injection for your basal, then a second one here, a third one here, and a fourth one here. So that's 4 injections a day. And that may be not very appealing to a lot of people, especially if someone comes in to your office for the first time, they don't even know they're diabetic, their A1C is 12, and you say, you need to be on insulin, I'm going to give you 4 shots a day, go to it. Very few people can handle that right away. And, just as an aside, a lot of times people go to the hospital and they're treated in inpatient settings, right? And I see this all the time. They're new diabetics or they've recently been diagnosed with diabetes. They go into the hospital for some complication and they're found to have high sugars. While you're in the hospital, it's absolutely easy to recreate that, right? You've got nurses checking your vitals every couple hours. You can check their blood sugar 4 to 6 times a day. You can dose some insulin as needed. You check their blood sugar after a meal and their sugar's high, let's give them some more insulin. And when they're discharged from the hospital, they've been getting like 7 or 8 shots a day. And someone gives them a prescription for that equivalent insulin management routine. It's going to be very difficult to follow. So these slides talk about all of your different insulin types, right? And it's very important to know these different types. It's important to know a little bit about the premixed insulins as well. These premixed insulins basically give you part of a longer acting and part of a short acting. So for example, if you wanted to recreate this curve with just 2 injections, you could give 1 injection here that gives you some basal and a short acting, and you could give 1 injection here that gives more basal and a short acting. And in 2 injections a day, you've almost recreated this insulin curve. It's not perfect, right? But that's the idea behind some of these premixed insulins. I know I'm going through this really quickly. So here's an algorithm that you can look at later that kind of talks about how would you start someone on insulin, right? You don't want to just start them on 3 injections a day. You'd start them usually on a basal insulin because that's 1 injection a day. Get their basal level of insulin up. Add injections with meals as you go on in their treatment process. Generally speaking, you know, you can have different treatment protocols. Roughly 10 units a day, 5 to 10 units a day is reasonable to start as a long-acting insulin once a day. Titrate that up. Yes.
So if somebody makes it to the point to where they're on insulin now, then should they really be on metformin and all the others, like, yeah?
Yes, so let me, in response to that question, I'm going to go down to some of these slides here. There's ways of rationally combining medications, okay? So these are all very complex slides, so I don't expect you to, you know, I don't want you to go blind by looking at them, but I'm pointing this out to show you that, you know, when you start someone, metformin is the standard in all of these. All patients who are on insulin should also be on metformin unless there's a reason not to be. Some people will say that type 1 diabetics are the exception. Type 1 diabetics, because it's purely an issue with insulin production, that you can treat them solely based on insulin. But all type 2 diabetics, you can see that you start them on metformin, and then there's ways of combining metformin plus other types of medications. You don't want to use insulin with medications like sulfonylureas, right? You're not going to give someone a medication that stimulates insulin production as well as giving them insulin, generally speaking. Although in some cases you could, and that depends on a very specific kind of patient. This is one example of a chart. This is my old clinic's chart. It's like a flow chart basically to how to decide what medications to put someone on. And it's a very complex flow chart, but on one hand, you know, you just kind of follow where you are with a patient. Let's say you have a patient with a A1C of 6.5, right? Let me see where that is. So that would be someone over here, an A1C of less than 6.9. You want to make sure that they are on metformin, add glipizide if needed. Actually, that's the chart for this pathway here. But this is very complicated, right? I'm going to go back to your point about the patient with an A1C of 6.5, because that's a very important point, right? Let's talk about goals, right? At the end of all this, let's say you've memorized all those treatment charts. What's the point? What do you want to achieve with those medications, right? Well, what you're really looking at is trying to get their A1C down to a reasonable level. Are you trying to normalize them? Are you trying to make every diabetic push them to an A1C of less than 5.7 so they're normal? No. Because what happens if you try and do that, right? The A1C is an average blood sugar, right? So if you're going to try and get someone down to an average level here, that means that part of the time they're still going to be higher than that, and a part of the time they're going to be a lot lower than that. And what we've seen is that the adverse consequences of trying to push someone's sugar too low means that you're going to get those people that drop into dangerous hypoglycemic levels and are going to have serious consequences. See where I'm at time-wise. So, strict control versus loose control. You know, there's a lot of articles describing what is your optimal blood sugar range, right? For a healthy person who's newly diagnosed with diabetes, you usually try and get them below 7%. For people with a lot of comorbidities, you know, maybe 7 to 8% is reasonable. In our clinic, we have a threshold of 8% for older patients with a lot of comorbidities. Like if we can try and get them below 8% or even 8.5%, we're okay. It's extremely individualized. This is a chart that you should look at and sort of understand, but this is to your point, right? How do you decide if you want to be more stringent? That is to say, you want to try and get their A1C lower, less than 7, versus less stringent. You're okay with their A1C being 7.5, 8, 8.5. How do you decide between those two criteria? Well, it depends on a number of different patient characteristics, right? Let's start with patient attitude, right? If someone comes to you and says, I don't care, I'm not gonna, there's no way you're gonna inject me with insulin. I don't wanna be on metformin, I don't wanna be on any meds, I'll figure this out on my own. You're done, right? Like, what are you gonna do? You're not gonna restrain them and give them insulin every day in your clinic. So, highly motivated, adherent patients, yeah, you can try and tell them this is what your goal is. We're going to try and get you down to this level. Patients that are less motivated, non-adherent, patients that don't seem to be able to know how to inject insulin properly, you don't want to, you're trusting someone with a potentially lethal medication, right? If they can't tell the difference between 10 units and 100 units on a syringe, and you're asking them to inject themselves every day, that may be a patient where you're going to have to accept a higher level of blood sugar because it's just not safe, right? Similarly, risks associated with hypoglycemia. If they're a patient who's particularly susceptible, elderly patients, patients with severe cardiac disease, alcoholics, people that are actively using substances, these are people that that may be profoundly susceptible to hypoglycemia, in which case that average, you're going to have to shift that average goal a little bit higher. Disease duration, life expectancy, important comorbidities, established vascular complications. Ironically, if someone already has a lot of end-stage vascular complications from diabetes, right? They already have severe neuropathy, they've had an amputation. They're obviously more fragile, and maybe the benefits of achieving extremely tight glucose control are not going to be as advantageous as someone who does not have any of these comorbidities, and you can prevent those in the future. Does that make sense? So, in the specific case of that patient, absolutely, like someone walks in, any given patient that walks in, it's just really hard to say, this is your goal, and we're going to shoot for that goal. It's going to be highly dependent. Video time, just to allow your brains to relax for a second. Think about any questions that you have.
Understanding Poetry. Understanding Poetry by Dr. J. Evans Pritchard, PhD. To fully understand poetry, we must first be fluent with its meter, rhyme, and figures of speech. Then ask two questions. One, how artfully has the objective of the poem been rendered? And two, how important is that objective? Question 1 rates the poem's perfection. Question 2 rates its importance. And once these questions have been answered, determining the poem's greatness becomes a relatively simple matter. If the poem's score for perfection is plotted on the horizontal of the graph, and its importance is plotted on the vertical, then calculating the total area of the poem yields the measure of its greatness. A sonnet by Byron might score high on the vertical, but only average on the horizontal. A Shakespearean sonnet, on the other hand, would score high both horizontally and vertically, yielding a massive total area, thereby revealing the poem to be truly great. As you proceed through the poetry in this book, practice this rating method. As your ability to evaluate poems in this manner grows, so will your enjoyment and understanding of poetry. Excellent. That's what I take Mr. J. Evans Pritchard. Not like pipe, talking about poetry. How could you describe poetry like American bandstand? Well, I like Byron, I'm a 42, but I can't dance to it. I want you to rip out that page. Rip out the entire page. Hear me. Rip it out. Rip it out. Come on. Rip it out. Thank you, Mr. Dalton. Gentlemen,
Great movie, right? So the point that I'm trying to make with that very long clip is just that, you know, when they talk about the art of medicine and the art of approaching your patients, you know, you can look at all those slides and charts, and those flow charts especially, and I don't suggest that you rip them out or delete them, but you have to understand that when you're approaching individual patients, that all those factors that you have to take into account, you're going to have to take those into account, and it's not going to be as simple as following a flow chart. It's important to know those flow charts because that gives your mind sort of like a guiding principle, and the number of people the patients that I've had that have actually been able to follow that flow chart is 0, right? Because people will not follow up with appointments, people will not get their labs in, people will be non-compliant. Some people will come in with an A1C of 7.5 and they'll meet with their dietitian and you'll discover that they're basically drinking 2 2-liter bottles of soda a day. And when you really, you know, pin them down on it, tell them to start cutting down with no medications, their A1C normalizes. Now, those are still diabetics, right? But they've managed to artificially create those A1Cs by just inordinate amounts of sugar intake. So, you know, when you're actually in practice, you're going to have a lot of complicated scenarios, and you're going to have to sort of negotiate them the best that you can. So we're getting close to the end. These are, you know, in terms of management and treatment of the complications, there's very strict protocols about what you do for your diabetic patients. You may see this as you're in practice with your preceptors, that, you know, every diabetic needs to make sure that they get their foot exam, for example, and document foot exam for early screening for neuropathy, yearly eye exams for screening for retinopathy, because you can, you know, if you know that in advance, you can focus on blood sugar control, you know, a little bit more stringently, or there are certain treatments for proliferative retinopathy for ophthalmologists. Nephropathy, the same thing. ACE inhibitors that we talked about, they're first-line therapy when you notice microalbuminuria. In the absence of hypertension in a diabetic patient, if they have microalbumin, you need to put them on an ACE inhibitor, even a low dose if possible. Cardiovascular risk factor management really comes down to 4 factors, right? Smoking cessation, blood pressure control, cholesterol management, and antiplatelet protection, or whether or not to give them aspirin. Skip this real quick. No, has anyone used these ASCVD risk estimators before? A really great tool. You can put in, just go to these websites. There's a number of them. You enter in these numbers. Now, just know that a lot of this data is based on the Framingham data from Massachusetts. So you're basically looking at data from a predominantly white male population. But having said that, it does include a lot of newer data, and so there's tags for race and ethnicity, and it gives you a pretty good tool for at least confronting patients, right, with some of this stuff. What I like to do is I put in a lot of patients' information, especially if they're a smoker, and I give them their risk score, and then I say, okay, what if you weren't a smoker? And I show them their risk score, and have them like confronted with, here's the data that says, you know, your risk for cardiovascular disease could go from 15 to 9%, or 15 to 5%, depending on what kinds of things we can fix, you know, we can treat. So this is what it looks like, sort of. You'll get a 10-year risk and you'll get a lifetime risk. Brief note about smoking. You know, this is obviously not a lecture on smoking cessation. I will be talking about this in December. The 5 A's, it's good to know these, primarily because what we often do is we do these first 2, right? We ask, are you smoking? And we say, hey, you shouldn't smoke. We don't really follow through on the assess, the assist, and the arrange. The assessment is really important. If you say to someone, hey, you're smoking, you should quit, how ready is that person to quit? they say, you're gonna pry cigarettes out of my cold, dead hands when I'm 100 years old. I'm smoking despite the fact that I'm connected to an oxygen tank as we speak. I'm smoking in the office with you. That person is obviously not ready to quit. You can assess this and you can encourage this through some motivational interviewing. Assisting them is really kind of negotiating like a treatment plan and arranging, following up visits. Having someone come in specifically for an appointment to talk about smoking cessation. Say, hey, this is the plan. We're going to have you come back in a month, and let's see where you are with smoking cessation. That's been shown to decrease rates of, or increase rates of quitting. And assisting also making sure you're aware of the medications that are available for this. I put tobacco first because it's by far the most impactful risk factor in cardiovascular disease, right? Hypertension. You can go through these slides. Someone was mentioning earlier about goals of blood pressure treatment. Goals for diabetics, still less than 140/90 is your goal, and over this is where you treat. Lower targets may be appropriate for certain individuals, but this is what we're shooting for. In the newest guidelines, they will say that for older high-risk patients, over 150/90 is also acceptable, but it's really important to remember 140/90. It's important to remember ACE inhibitors or ARBs are your first line treatments for diabetics. But other than that, your treatment is going to be pretty much the same as treating basic essential hypertension. Cholesterol. So we used to think about trying to focus on your LDL and saying you need to get your LDL to this number. That's not the way I tend to think about this anymore. The way that you should think about it is when you do those risk calculators, you'll basically say whether someone falls into the category of needing a high intensity statin or a moderate intensity statin, moderate to low intensity statin, independent of really their LDL, because statins have been shown to reduce cardiovascular morbidity and reduce adverse events. So really some of these patients should either be on one column or the other. It's very difficult to get rosuvastatin or Crestor, which is a very expensive high-intensity statin. So you're basically deciding whether they need to be on high-dose Lipitor or one of these other statins. A lot of this is depending on side effects, on other indications. Simvastatin is a commonly prescribed statin, but it interacts with a lot of other medications. Anytime you see these slides, these are directly, I got lazy towards the end, and so these are directly pulled from the ADA slides. But they basically give you all the evidence that you need to know. You can sort of assess someone based on their risk factors or that calculator, and it'll tell you whether they need to be on a moderate or high intensity statin. A lot of this stuff is just, you plug in the numbers and it tells you what to do. Same thing with aspirin. You go to those ASCVD risk calculators. Generally speaking, if your 10-year risk is greater than 10%, then aspirin has been shown to have benefits. Don't forget aspirin has side effects, right? GI bleeding, upset stomach, blood thinning in general, bruising. So aspirin is not for everybody, but it is important to know when it is indicated. The problem with this lecture is that I get to this point and I'm flying through it and I'm really not doing justice to some of these treatment modalities. The most important thing that I want you to take away from this, though, is that most clinics now have some sort of a team-based approach, whether you use a behavioral health provider to help manage someone's adjustment to chronic diseases, having a nutritionist, or having the ability to refer to nutrition classes or individualized diabetic educators. I rely on our diabetic educators tremendously for not just for coaching our patients through the initial stages of diabetes, but also for treatment recommendations. They're on medications. They're, depending on when you take certain medications, whether you're on extended release formulations, immediate release formulations, there's a huge range of the art to treating diabetes, I guess I should say. So the more you can do to shadow, maybe during your rotations, try and shadow dietitians and certified diabetes educators, go to classes, just get some of these educational topics, these things that you can tell your patients, just get them down so that you know them right off the top of your head, like suggestions you can make. Reducing sugar intake in drinks, for example, is the one thing that I always focus on. How many sodas are you drinking? How many sugary drinks are you drinking? because that's a high yield kind of target. Let's see. Briefly talking about gestational diabetes. Gestational diabetes is its own separate topic in terms of management. There's a lot of programs in obstetric offices or referral programs for referring these patients to get better treatment of gestational diabetes, mainly because hyperglycemia in pregnancy can lead to maternal fetal complications. Maternal insulin does not cross the placenta, but glucose does. So if a fetus is seeing high levels of glucose, that fetus is going to produce its own insulin in response to that. And the effects of fetal insulin production are going to be macrosomia. These are larger babies because insulin is a growth hormone essentially. And after they deliver, after that high sugar environment is there, these babies will be more prone to hypoglycemia, so they'll need to be monitored. So the more that we can do to manage maternal glucose, the better during pregnancy, which is why management is slightly different. There's more sensitive methods using the 1 hour and 3 hour oral glucose tolerance tests to really catch these pre-diabetic or diabetic, gestational diabetic mothers, and more aggressive blood glucose control. Women are more likely to be started on insulin to really get those sugars under control. And usually there's a specialized team, a nutritionist. Usually these mothers are referred to a perinatologist as well. And then I'll just briefly talk about, it's important to know some of these terms as well, because we've basically spent this entire talk talking about type 2 diabetes or adult onset diabetes, which is also called non-insulin dependent diabetes, but as we see, some of those people will become insulin dependent. Type 1 diabetes is juvenile onset, and it's usually an autoimmune condition that triggers, let's see, I have a slide on, occurs in youth. It's caused by autoimmune destruction of the pancreatic beta cells. Important to know that they essentially face the same risks as type 2 diabetics. They tend to not have the same metabolic complications. They tend not to be obese, but because they're exposed to higher sugars for a longer period of time, they can develop those microvascular complications much earlier in life. And then, I know I'm skipping around here. Just know some of these terms, right? Insulin dependent versus non-insulin dependent, juvenile onset versus adult onset. These are sort of boundaries that are being blurred these days, but you might hear people still talk about diabetes in these terms, which is not completely accurate, but I think it's important to know what those mean. There's these two distinct disease entities: latent autoimmune diabetes of adults, which is basically not that insulin curve that we talked about where your beta cells burn out, but you actually get autoimmune destruction of those beta cells later in life. So these could be thinner adult patients that show up with DKA, and they essentially have type 1 diabetes, but that has been initiated later in life. Versus this idea of maturity onset diabetes of the young, which is not, so it's diabetes of the young, so these are younger patients who will show up and present with what looks like type 2 diabetes, but they don't necessarily tend to be obese, and it's a specific genetic abnormality in insulin production. So just know what those terms are. Let's see where I am right here, 12 o'clock. The first time I did this, I just had a dog. Now I have a 16-month-old daughter, so I have to give her equal time on the slide. So it's noon. I know there's probably a lot of questions. Maybe we can take a couple, and then maybe you can give my email out in case there's other questions that pop up later.
How often do you see true hypoglycemia in family practice?
True hypoglycemia meaning?
Not related to medications.
Not related to medications, where someone just comes in and they say, oh, I'm getting hypoglycemic. I would say never, but I've probably seen it a few times. The cases where you will get hypoglycemia in a non-diabetic who's not factitiously using insulin or medications, alcoholics, right? Alcoholic liver disease will reduce your ability to produce glucose. Hepatic glucose production is diminished in alcoholic cirrhotics. So absolutely alcoholics can get hypoglycemia. And then, if that's truly happening, there are insulin-secreting tumors that are rare, but that can occur, and those patients will present with random hypoglycemia. If it's not related to any other kind of medication or those two things, in general, people might feel hypoglycemic. People can have relative hypoglycemia, but true hypoglycemia is a blood sugar under 60. And really symptomatic hypoglycemia is when they're 40 or even less, where you'll basically lead to the symptoms of hypoglycemia, which I didn't actually talk about, but jitteriness, sweating, nausea, all the way down to loss of consciousness and coma, right? So I haven't seen anyone that just spontaneously comes in with that.
I actually have that.
So do
I have that, and I don't drink alcohol, I'm not on medication, and I have been diagnosed with that. And I could tell you from my own personal experience, it will come randomly, and I've got maybe 5 minutes if I don't eat something. I've almost passed out, like several times at work, and it'll be like, my blood sugar will be like 40. So.
I should say,
I don't know why.
I should say that I have
overreactive pancreas. So my blood sugar drops a few hours after. I'm not been able to control the diet, but it's like my pancreas doesn't know when to cut the insulin off. So I will drop after like 3 hours after a carb. I can't just do the breakfast cereal or milk.
Yeah.
And so I'm not, I'm not overweight. I do have both types of diabetes in my family, and I guess it's been linked to more of a precursor to type 2 because you're just having trouble regulating the insulin.
Yeah.
That's getting produced, and eventually your pancreas can keep out in a sense. But yeah, I did the 5-hour not being pregnant glucose tolerance test, and all I had is after a certain period of time I had 42. And
I couldn't make it through. I couldn't make it through all of the 5. I was at 42 on like the second or third one.
That's how I was.
Yeah.
And they left me there, and then eventually I picked back up. And it felt awful. So.
I will say, I take it back because I have, in working with our dietitian, I have had a couple of people who have had similar syndromes like that. I'm sort of, I have seen it rarely. Obviously, you guys are both here, so it's not impossible. So it's not something that I'm super familiar with. I'm sure if you talk with some diabetic educators and nutritionists and endocrinologists, you probably see more of that. Yeah.
Well, and my caveat to that is when I was trying to figure out what was going on, because I thought I might be swinging and having these highs that I wasn't recognizing. The physician I had, and of course this was before I was a nurse, and I was actually on Medi-Cal and in a clinic that was, a lot of patients or anything, but that's who we're serving, was, oh, they're not high, so don't worry about it. And I just kept, getting to points where I felt awful, and it was my own research, and then when I got to another physician later in life, he's like, okay, this is, I'm like, oh, I knew that was what was going on, But if it's not exactly, your patients don't fit the mold, we shouldn't just shrug them off and, I know we deal with a lot of patients that have psych issues and stuff, and that can be their own thing, but I'm just not always like.
Yeah. Thank you for sharing.
As everything from nursing school, it's stuck with me, and I've explained it to patients that are newly diagnosed diabetic, for them to understand what's going on. Tell them warm and dry, sugar is high, cold and clammy, we need some candy. So, and that sticks with people, because then they realize, oh wait, I'm sweating and I'm shivering, and that I need some candy. So it really just stuck with me, and I thought it was kind of a nice layperson's way of explaining to patients.
A lot of the stuff because you're all going to see diabetes over and over again in your preceptorship. So a lot of the things that you're going to pick up in the management are going to be things that you'll pick up from your preceptors. These gray areas of what do you do when someone's got a A1C of 6.5 or when they're older and it's 7.5. And so, I think it's important to know, like I mentioned, be familiar with these protocols, what endocrinologists say. The ADA website and this link right here, really the clinical practice recommendations, it's really good to know these really well because that's what tests are going to be on. And then it's also important equally to see what you see in your clinic how your preceptor works. Not all preceptors are obviously going to be perfect, you know, so you're going to have to kind of get a sense of what you think seems to be effective, what isn't effective. You know, don't forget about, you know, blood glucose control is really just one small part of the management of diabetes. You got to look at the whole patient, and don't forget about Dead Poet Society, and rip out the parts of the book that are not applicable, you know.
I have one question.
Sure.
So this is like off topic, but I have a provider, he'll order insulin IM. I made multiple calls to like pharmacy. So I go to him, so doc, insulin IM. His reasoning is that it works faster, it's better, and it stays in your system longer. So then I've done like research on it, and it's true, people old school I guess, used to do it IM for those reasons.
So
like,
the
so
patients
doc,
themselves will inject
Yeah.
IM insulin? Well, I mean, you know, I don't know how many people in this room would want to give themselves one IM injection daily, let alone 3 or 4. I mean, that seems to be, you know, bordering on torture. But I don't know. I don't know that data.
Well, now that inhaled insulin's out too, that's gonna change.
That's interesting.
We talk about something that's coming up on the horizon. I have 2 friends that are on it, and they're like, this is like changing.
Yeah. I mean, I've been hearing about inhaled insulin for a while now, and granted, I work in a low-income community clinic as well, so I've not yet seen anyone on it or been able to get it. But, you know, subcutaneous insulin injections are relatively, you know, there's a lot of fear associated with them, but anyone that's actually given themselves those sub-Q shots, they're not too bad. And there's the newer formulations of pens, insulin pens, are really a good way of sort of like managing a low-cost way of providing insulin, you know? I mean, with the inhaled insulin and everything like that, I mean, you saw the numbers, right? 30 million diabetics, you know, if even a tenth of them need insulin on a regular basis, you know, we're not going to be able to afford as a society to give people even insulin pumps, let alone inhaled insulin, all these things. We're going to have to use what's cheap and what's effective, you know? So, but yeah, I'll have to look up IM insulin data.
Yeah, it's interesting.
Yeah.
I only had to give myself one IM once in my thigh, it was a B12, and it took me a good 3 minutes to actually force that needle into my thigh.
Yeah.
And it was awful, it was absolutely awful.
Thank you.
Thank you.
Yeah. You guys, if you have any questions, feel free to email me.